अभी
Please let me know once it's.
फर्स्ट सेशन के चेयरपर्सन तो मैम नहीं आए हैं। आई
नहीं,
कांट।
उनको फोन करना पड़ेगा मैम, व्हाट्सएप कॉल कीजिए ना
मैं
प्लीज।
करती हूँ। डॉक्टर किरण सिन्हा, डॉक्टर कल्पना दीक्षित, डॉक्टर छाया गोयल। मैं करती हूँ।
यस मैम।
या
We are
Team
live.
Corona, yeah. Okay. Should I start?
Yes.
A very good evening and wishing you a belated happy International Women's Day to all. This is the 223rd edition of the Happy Learning Masterclass series. This episode today is in association with Ghaziabad, Greater Noida, Khora, Makhanpur, Kanpur societies. And today's theme is endometriosis. 1 in every 10 women of the reproductive age group suffer from this condition, spending years seeking a diagnosis. To some, it means severe dysmenorrhea, and to some, it is chronic pelvic pain and infertility. Today, we unreveal the mystery behind endometriosis with managing the medical diagnosis, the surgical treatment, the medical legal aspects, and a case based discussion on endometriosis. The program director for today's program is none other than Dr. MC Patel, sir. Let us invoke the blessings of Lord Almighty before we start this program today. Can we have the inauguration slide, please?
Yes.
It is my proud privilege to introduce none other than Dr. MC Patel, sir, today. He has been the past vice president of Foxy, a senior medical legal consultant known all over India, an active Alliance member, past president of the Ahmedabad OBGY Society and IMA Ahmedabad, and the organizing chairperson of Vivekanand NMO. Sir has been very actively involved also in social services and camps across the Northeast since the last 33 years. It is my proud privilege to welcome you, sir, on the platform. And over to you for your blessings.
Thank you, Dr. Monica, for kind words. It gives me immense pleasure to welcome you all to this 223rd episode of Happy Learning Masterclass web series. And just mentioned prior, Ghaziabad, Greater Noida, Khoramakanpur, Kanpur and Noida is the joining society today for this webinar. I welcome Dr. Meera Agnihotri Madam. She has kindly consented to be chief guest to bless us for this webinar. Of course, she is always with me in any of my academic activity. Thank you, Madam, for sparing time for me and welcome. I also welcome Colonel Dr. S.S. Gulati sir from Greater Noida. He is also always encouraging force with me in any of my academic activity. So welcome Gulati sir. I also welcome Dr. Archana Verma from Ghaziabad. She is past Vice President Foxy. She has also kindly consented to be guest of honor to bless the webinar. I also welcome Dr. Kiran Pandey. He is instrumental for this webinar particularly. So welcome Kiran Pandey Madam. I also welcome Chairperson Dr. Kiran Sinha from Kanpur, Dr. Kalpana Dixit Madam from Kanpur, Dr. Chaya Goyal from Ghaziabad. They are going to chair a very interesting session of medical management of endometriosis, and which is going to be delivered by Dr. Kanchan Sharma. I also welcome one more set of chairperson, Dr. Manisha Saxena from Noida, Dr. Archana Sharma from Ghaziabad, and Dr. Nilam Mishra from Kanpur. They are going to chair very interesting session of surgical management of endometriosis, and it is to be dealt with by Dr. Pratik Kanani from Ghaziabad. I also welcome one more set of chairpersons, Dr. Alpna Agarwal from Ghaziabad, Dr. Kanchanmala Gupta from Kanpur, and Dr. Archana Mehta from Greater Noida. And they are going to chair this interesting session. I also welcome two learned moderator, Dr. Aradhana Singh Bundela and Dr. Jigna Govil. They are going to moderate troubleshooting in management of endometriosis, and it will be a nice panel. And for that, Dr. Sanchita Dubey, President of Noida Society, is expert panelist. She is going to put his expert remark during panel discussion. I also welcome all the learned panelists, Dr. Mithi Banod from Noida, Dr. Sweta Mathur from Noida, Manisha Agarwal from Ghaziabad, Dr. Reshma Nigam from Kanpur, Ritu Mittal from Khoramakanpur, Samta Gupta from Greater Noida, Dr. Gunjan from Khoramakanpur, and Dr. Apurva Asthana from Greater Noida. I also welcome my team, Dr. Monica Umardan, she is convener for this series, Dr. Monica Gupta, Dr. Nivedita Datta, Dr. Deepika Logani, Dr. Satabdi Day, and Dr. Megha Kamlapur. They are coordinator for this series. And I welcome all the president and secretary of joining society and all the delegates. So when we started this series in era of COVID-19, where physical meeting were not possible, and just to meet our Foxian friend, to say hello and to discuss focus topic was our aim. And at that time, we started with 4 people. And now I am happy to announce we are more than 8,000 member of Happy Learning Masterclass web series. And we usually discuss very focused topic to be helpful to our Foxian friend to deal with day-to-day problem with our patient. Our ultimate goal was to check maternal mortality and infant mortality, and at the same time to ease our comfort level of our patient. As far as endometriosis is concerned, rightly mentioned by Dr. Monica, the symptom is pain, pelvic pain, chronic pain, and many a time it becomes a headache for us also, gynecologists, how to deal with situation, because uh, a consistency of symptom is very much there, and recurrence is also known with this, and that is why we are always on toes whenever we are dealing with any case of endometriosis. So to discuss this focus topic, today we are here with 223rd episode of Happy Learning Masterclass web series. So without wasting much of your time, welcoming you all. Thank you very much.
Thank you, sir. It is always a privilege to work with you. And now I have the privilege to introduce Dr. Kiran Pandey, Madam, the past chairperson of the Medical Education Committee, FOXY, the professor and former head of the department at GSB Medical College at Kanpur. Madam has been of immense help to coordinate this program together. Ma'am, we invite you to introduce our chief guest for today.
Thank you. Thank you, Dr. Monica. And before I introduce my chief guest, our chief guest, I would like to first acknowledge the efforts of our program director, Dr. MC Patel, and and you yourself, who have done, along with our whole organizing committee, worked tirelessly to take this program to this. And as Dr. Patel has said, the endometriosis is a challenging event today, and we know that our master class is going to focus on this relevant and challenging topic. And you already know how much Dr. Patel has been working together for years, and that is why today's 223rd episode is there of this Happy Learning. I have been along with Dr. Patel in many of the episodes earlier also. I'm really thankful, sir, for giving me this opportunity many a times, and I'm sure this academic discussion, which is going to be into the with the respected chairpersons, the speakers, the panelists of different societies. What a platform! I mean, the Dr. Ghaziabad, Greater Noida, Khora Makanpur, Kanpur, Noida, all have come on this one platform to provide the valuable clinical sites and stimulate the meaningful academic discussion. So, with these words, I would like to introduce our chief guest, Dr. Meera Agnihotri, madam, and who doesn't know about her? She's not only known to Kanpur, but to UP, but to India. I think each and every person at every place must be knowing about herself whenever she's a very respected academician of our fraternity. Madam, you are a mentor of mentors, teacher of teachers, and even president of presidents. So you are everything to all of us, and you have been such a loving, guiding person. And I'm really privileged to be given this opportunity. Once again, thanks to the Dr. Patel and the organizing committee. But I would like to introduce you officially also with viewers. Besides being the distinguished academician and inspiring leader, Madam has served as a
Kiran, I
professor.
think we must not waste time.
Ma'am, 2-3 lines at least, 2-3 lines. Many of the youngsters might not be knowing that much how much you are working at this age and with all of us. Madam has been professor and head of the GSVM Medical College, Kanpur. And I have also been privileged to work under her and in her under her legacy. And Madam has been the represented FIGO conference in Montreal. She has been a visiting consultant of Bayer College of Medicine, Houston, and she's still working as an ethics committee chairperson into the medical college, which is really we had, madam, we had soft to your efforts, and she's a very passionate for the women's health, and she has established a Triple W Foundation. So these few words, at least those of
Thank you.
you might not be knowing so many things. I know if I will not read the whole CV,
Thank you,
because
Kiran.
then it
Thank you
will
very
be
much. It's
thank you,
okay.
madam, for please bless us with your and guide us for further
Right.
programs. And one word, just I would before that, I also welcome the guest of honor, Dr. Colonel Surinder Gulati and Dr. Archana, if she has joined. So, madam, please bless us with your knowledgeable words.
At the outset, I extend my heartfelt gratitude, Dr. Patel, Dr. M.C. Patel, my younger brother, my great friend. We have been together at very many platforms, not only on the Happy Learning Masterclass, but otherwise also. And whenever his name comes, you see, first thing Kiran must agree that some medical legal things come to our mind. Ki yes, it will be solved by Dr. Patel. So he is a very innovative personality by understanding only that 223rd edition of this Happy Learning Masterclass is going to be there. And it's a really, really very innovative, whether it was started in the Corona period or otherwise. We know that he is very innovative, very nice, friend, philosopher, and guide. Whenever you call him, any day, any time, you will never listen no. Yes, I'll be there. So that is Dr. M.C. Patel. To give him a big hand from my side. I congratulate him for his academic ventures. I congratulate him for his social ventures. I congratulate him for his leadership qualities and his work in the medical legal aspect. I'm really honored and feel blessed to be sharing the dais with guest of honor, Dr. Gulati, and my lovely friend Archana Verma. I can't see her face right now, but I'm really very happy that I'm there with both of them. Kiran, she has been UC chairperson of such an important committee, and I believe she will continue working.
Yes, madam. Yes.
Two important things, I will like to add that the two chairpersons from Kanpur, Dr. Kiran Pandey and Dr. Kanchan Sharma, they will always be there with you to continue the messages from Kanpur, and all over the country. So I wish them good luck. Past Vice President Dr. Archana Verma, she's a very nice personality and great academician. I really love her and extend my blessings. Today's subject is very interesting. It is a never dying subject. Every day you start the book and you will add something new to it. And I'm very happy that it is the need of our and demand of the time to discuss such a subject, its medical aspect, its surgical aspect of management, and most importantly, the legal issues in the management of endometriosis, which will be discussed by none other by Dr. M.C. Patel. The first lecture to be done by Dr. Kanchan Sharma. We all know that she is chairperson of a very important committee, that is NCD committee, and I think she will do justice. We have got great hope from her. She works very hard and she will be presenting it very nicely. Thank you very much, all the persons present over here, all the chairpersons. I know them personally. I should have taken their name personally, but it will take lot of time. Therefore, I extend my heartfelt love, blessings, and thanks for making me a part of this august gathering and this important subject. Thank you, Dr. Patel. Thank you, Dr. Kiran. Thank you, Kanchan, and
Thank you.
surgical management speaker, Dr. Prateek, and medical legal aspect discussed by Dr. Patel. Thank you once again, and I extend my heartfelt blessings for the success of this webinar. Thank you very much.
Thank you, madam, for sparing time for us. You are always with us in any of our academic activity, and your mere presence is enough to bless us and to encourage us to continue our academic activity. Thank you, madam.
Thank you, sir.
Thank you, Meera ma'am. You are a source of inspiration to all of us who are working as juniors in Foxy. Thank you so much, ma'am, for being there with us on this platform. And now to introduce our guest of honor, Dr. Surendra Gulati, sir, has been in Army since the last 30 years. He has more than 34 years of teaching experience. He's the founder, president of Greater Noida, and she's chaired and delivered various lectures in conferences. We welcome you, sir, for your words of blessings. Gulati, sir. Please unmute yourself, sir. Sir, you need to unmute. Yeah. Still not, we are not able to hear you, sir.
सर आप म्यूटेड हैं.
सर राइट हैंड साइड पे एक स्मॉल बटन रहेगा अनम्यूट किया सर.
Sir, you are
The tech
muted.
team, can you please unmute, sir, if you're the host?
Corona team, because he is not able to unmute.
I'm trying, madam.
I have sent sir a request to unmute.
Till then, we can introduce Dr.
Yeah,
Archana
yes,
madam
yes,
and
sir.
have blessing from her.
It is also my privilege to introduce Dr. Archana Verma, madam, who is also the past chairperson of the Public Awareness Committee, the past vice president of Foxy from 2021. She's the founder president of the West UP ISOPAP chapter, past president of the Ghaziabad Society, and executive member of the Endocrinological Committee, SAFOG. She has been an India Book Award winner, the DC Datta Award for the Best Foxy Focus, and UP Governor Award for RTI for Uttarakhand Governor Appreciation Award. Ma'am, it's an honor to have you with us today on board. Can we have your blessings, please?
Very good evening, everybody. Namaskar to Adarniya Dr. Meera Agnihotri Madam and Dr. MC Patel sir. I'm a very small person and I need not say about my post and all. I think webinar में हमें सब कुछ cut कर देना चाहिए तो much better. And it is, I must say, the leaders like Dr. Patel makes everyone feel supported, guided, and of course valued. So their positivity and mentorship keep the entire team motivated and moving forward. And I have introduced into the Foxy, by the way, by our Dr. MC Patel sir only. So he is always guides, and this awareness about endometriosis is much more needed because there are a lot of confusion and clarity has to be done. And so I think, thank you very much, Dr. Kiran Pandey ma'am, and Public Awareness Committee Chairperson Monica, and Dr. Kanchan Sharma. I can see so many people here, and my namaskar to each and everyone. And Gulati sir, unmute कर लीजिए और बोलिए नमस्कार. Thank you. Thank you.
Thank you,
Thank
Archana. You are a
you.
very humble person.
Thank you, Dr. Archana. Of course, you are always with us in any of our activities. Thank you very much.
Gulati sir, can we have you now?
I think who's
Tech-
technical
tech
person
team, can we please?
help them.
Some
No,
technical
madam, it's
issue.
there. It's
Then
from
he
that
is
side
unable
only.
to
There,
unmute?
doctor can only unmute from his side.
तो
नहीं,
आप
agree.
उनको
We
फोन
cannot
करके
control.
कुछ बता दीजिए
हाँ.
कहीं पे कुछ प्रॉब्लम हो रही है.
There is some technical issue, I think, from
I'm guiding you.
his side, yes. So till then we can continue with our program. Whenever
Yes.
Dr. Gulati sir joins, we will take his blessing at that time. No issue.
Yes.
Definitely. So with this, we conclude that the inauguration is over, and I request all the societies who have been participating to actively please support Sir's candidature for President Foxy in the year 2026. It's a humble appeal to please support him. And I request Dr. Deepika Logani, madam, to please take over for the first session.
So, thank you very much and good evening to all esteemed faculty and delegates. And at the outset, thank you so much, Dr. MC Patel sir and Dr. Monica for giving me this opportunity. And now it's my privilege to start the scientific session. So we begin with the scientific session number 1. The topic for this session is medical management of endometriosis. It is my privilege to introduce our esteemed chairpersons for the session. So could we have the first slide, please? So our first chairperson for the session is Dr. Kiran Sinha ma'am. Ma'am is the past president of Kanpur Obs and Gynae Society. She is a senior consultant obstetrician and gynecologist at Kanpur and has retired from PMHS as Joint Director Kanpur Mandal after an illustrious career spanning 35 years of service. Ma'am has actively trained and conducted several government programs, including SIF, PSA, and family welfare initiatives, and is presently the Senior Secretary of Kanpur Obs and Gynae Society and Secretary of ISOPAR. We welcome you, ma'am, as our chairperson. Can we have the next CV, please? Our next chairperson is Dr. Kalpana Dikshit, ma'am. Ma'am is the president of Kanpur Obs and Gynae Society. She's a senior obs and gynae, obstetrician and gynecologist, infertility specialist, and director of Jeevani Hospital. Ma'am has played an important academic role as organizing secretary for Foxy National Presidential Conference and also for the Indian Menopausal Society annual conference. So we welcome you, ma'am, as our chairperson. Can we have the next? So our third chairperson for this session is Dr. Chhaya Goyal, ma'am. Ma'am is the Secretary of Ghaziabad Obstetrics and Gynae Society, being an alumni of KGMC Lucknow and has served as ex-CMO of CGHS and is presently a senior consultant obstetrician and gynecologist at Hira Lal Hospital, Ghaziabad. We welcome you, ma'am. Can I request our chairpersons, one of our chairpersons, to please introduce our first speaker for the session, Dr. Kanchan Sharma, ma'am, and ma'am will be speaking on the medical management of endometriosis. So, Dr. Chhaya, are you there?
Any chairperson can take.
Yeah.
or from our team if nobody is there?
I think Dr. Chaya is there. Madam,
Yes.
आप unmute करिए. Dr. Chaya, you are muted. Ma'am, we can't hear you. You are muted. There is some problem, I think, for the. So should I introduce?
Hello.
Yeah, yes, ma'am.
Welcome, welcome.
Dr. Chaya, yes. Welcome, Dr. Chaya. Please introduce our speaker, Dr. Kanchan
Our
Sharma, ma'am.
speaker, Dr. Kanchan Sharma. She is MBBS, MS, FICOG, FI CMCH, Director and Senior Consultant of Akash IVF Kanpur, practicing for last 35 years. She is laparoscopist, colposcopist, and ART specialist. She has many academic achievements, speakers in more than 600 national and zonal conferences, chaired more than 500 important sessions, and she has organized national conferences at Kanpur, National President NCD Conference in 2024, UPCon in 2015. She has many publications, published book on NCD, updated as a chief editor through Foxy, and she has many awards and achievements. So please, I welcome you, ma'am, for your session. Dr. Kanchan Sharma, ma'am, over to you.
Thank you, Dr. Chair.
Thank you, ma'am.
And first of all, my regards to Professor Dr. Meera Agnihotri, madam, who is mentor and present here, and regards to Dr. MC Patel, sir, who has given us chance for learning, as the name is of the series is Happy Learning. Happily, we are learning since last many years, and you can see, of course, that this is 223 episode. And really, as Meera madam said, he is the friend of each and a guide, mentor of each and every one of us. And he's always there. Whenever we call him at any odd time, even he responds very well. Thank you, and my best wishes for his presidentship in the coming election year. My regards to Dr. Kiran Pandey, Dr. Surinder Gulati, Dr. Archana Varma madam, who all are there, and all the moderators. Let us share my screen.
Yes, ma'am.
Just want to share my screen.
Yes, ma'am. Please go ahead, ma'am.
Make it full screen.
My
fine.
screen is visible.
Yes,
Yes,
ma'am.
visible.
Okay. So, as the topic given to me is the medical management of the endometriosis. The slides are moving. Yes. So, endometriosis, as we know, is defined as the presence of endometrial-like tissue outside the uterus, which induces a chronic inflammatory reactions. This is known as the disease of celebrities, as opposite to PCOD. PCOD is a disease of obese, heavy-weighted person. This is a lean, thin persons, celebrities. This March is being celebrated as the Endometriosis Day worldwide. Annually, during the first week of March, 3 to 9, we celebrate as a Endometriosis Awareness Week. Today is the 10th March. There are few key factors of the endometriosis, which we all should know. Endometriosis that affects roughly 10% of reproductive age women and the girl globally. Of course, this is a chronic disease associated with severe life-impacting pain during the periods. Patients are coming to all of us. They may be having pain in the sexual intercourse, bowel movement, urination, or maybe having chronic pelvic pain, abdominal bloating, anxiety, depression, and infertility. That all depends on the site of endometriotic nodule. Endometriosis-related pain is attributed to increase in the inflammatory mediators, neurological dysfunction, and the estrogen-mediated neuromodulation of the peripheral sensory neurons. So, how do we do the definitive diagnosis of endometriosis? It can only be made by histopathology. Otherwise, it's very difficult to do the definitive diagnosis of endometriosis. There are no serum markers which are currently available. You can say about the CA-125 level, which can be elevated. However, it is elevated in many other conditions also. There are few imaging studies like ultrasonography, CT, and MRI. These are helpful only in the cases of where there is endometriotic ovarian cyst, that is endometrioma, or some adnexal masses. So, the estrogen is the main culprit. There is increased production of estradiol, increased intrinsic aromatase activity, increased production of inflammatory markers, and even progesterone resistance. So, as the endometriotic lesions are hormonally active, you all are knowing, modifying the hormone milieu of the body that helps in suppression of the lesion, and it suppresses the inflammatory mediator leading to pain. The medical management of endometriosis is targeted towards controlling pain and suppression of the hormonally active endometriotic tissue. So endometriotic related pain that is leading to dysmenorrhea, pelvic pain, dyspareunia, dysphagia, that is most common presenting complaint and can seriously affect the quality of life of women and even cause mental and emotional disability. What are the symptoms typically associated with endometriosis? Maybe severe dysmenorrhea, maybe deep dyspareunia, maybe chronic pelvic pain, maybe ovulation pain, maybe cyclical or perimenstrual symptoms such as bowel, bladder, with or without abnormal bleeding or pain, infertility, very common presentation, chronic fatigue. These all features depend on the site where endometric nodule is there. Dysphagia or the pain on defecation. Sign, the deeply infiltrating nodules are most reliably detected when we do the clinical examination, especially during menstruation. There may be pelvic tenderness. There may be fixed retroverted uterus. There may be tender uterosacral ligaments or enlarged ovaries. So, coming on, what is the gold standard diagnostic test? Is there any? Visual inspection of the pelvis at the laparoscopy is the gold standard, but there is a major risk of bowel perforation, vascular damage. How does it appear? It appears blackened spot, red implant, vesicles, peritoneal defects, and even endometriomas. What is the drawback is a diagnostic delay that happens from 3 to 11 years. There are a lot many papers, even in our practical life, we have seen that a patient, young patient going from one doctor to other with the pelvic pain, these type of the pain, severe pain in abdomen, and not being diagnosed. Initially, we diagnose it as a PID or any other cause. Ultimately, that happens to be diagnosed as a endometriosis after 3 to 11 years. There are not many papers of this diagnostic delay. So endometriosis that affects in 1 in 10 women during their reproductive years. So there is average diagnostic delay. This is a picture which shows that during the time of Socrates, they used to treat this endometriosis like this. They thought that the uterus has gone mad. Therefore, they hang the woman upside down and rotate her side by side. And they think that by this, the endometriosis uterus that settles. There are two main symptoms of the endometriosis, that may be a pain or the infertility. There are major discussions among surgical versus medical treatment. Because it is a disease of lifetime, recurrence are frequent and no cure confirmed till date. Surgery should be reserved for the infertility growing cyst, and IRV nodule or the definitive. So there are no conclusive evidence to make any definitive recommendation on whether the medical therapies or the surgery are more effective for relieving pain in the woman with endometriosis. In surgery, the results are instant, but recurrence is common. So for the recurrence, again, you have to give the medical treatment. The pain symptom, medical treatment is for all ages, is the first line treatment. In the young girl, where there is a surface or the smaller cyst, you give the medical treatment. Woman who is not yet ready for the pregnancy, you can give medical treatment. The recurrent endometriosis, you can give medical treatment. And when the diagnosis is not confirmed, as the young girl that comes and you are not confirmed the diagnosis, you can give a course of OCPs and watch whether there is a relief or not. Endometriosis is estrogen dependent, and almost all the medical therapy is directed to oppose the estrogen environment. What does these treatment cause? They cause ovarian suppression and help to reduce pain. They does not help in improving the pregnancy. Post-op therapy also, when given with the medical treatment, reduces recurrence. So here this is helpful. Now coming on, what are the medication which can be used? These may be hormonal, they may be, first I'll read the headings. These are the combined oral contraceptives. These may be progesterone containing contraceptive or maybe selective progesterone receptor modulator, maybe gonadotropin releasing hormone agonist, maybe gonadotropin releasing hormone antagonist, maybe non-hormonal like NSAID, aromatase inhibitor and danazol. So among the hormonal, progesterone containing contraceptive, they may be oral or injectable, maybe implant, maybe LNG-IUS. If they are selective progesterone receptor modulators, they may be mifepristone, maybe uliprestone acetate, maybe onaprestone, gonadotropin releasing hormone agonist. These as we are using leuprolide acetate, nephrolin, gosarlin, while gonadotropin releasing hormone antagonist may be oral or may be injectable. So coming on NSAIDs. NSAIDs are most commonly used first-line agent in the management of endometriosis, related pain and dysmenorrhea. These act by blocking enzyme COX, what is crucial for the production of the inflammatory mediators. Although both COX-1 and COX-2 receptors are present, so studies have shown that ectopic endometrial tissue have a higher concentration of COX-2 receptors. Both selective and non-selective COX inhibitors are widely used for symptomatic relief. So along with pain control, new studies have shown that selective COX-2 inhibitors like troficoxib can also inhibit the growth of the endometrial tissues. So coming on the combined hormonal contraceptives, these are most commonly used because they are easy to use. They cause the suppression of ovaries and the disease activity form the basis of the use of the hormonal contraceptive and endometriosis. Estrogen and progesterone combination or the progesterone alone led to deserialization of the endometrial tissue and is proposed to slow the progression of the disease. So these have been used with the varying degree of success in the women with the endometriosis. There's one is of the cost and easy tolerability and easy administration. There may be two types, maybe cyclical or maybe continuous. Both are preferred according to person. In the continuous, there is no period, while some prefer having a period in between. There are low dose also which are available. So hormone therapy for the endometriosis, their mode of action is always to suppress the estrogen production. Progestin selective progesterone receptor modulators and combined contraceptive. They block the ovulation through the central inhibition of the gonadotropin release. They induce amenorrhea, which prevent repeated menstrual reflex and have many direct effect on the endometriotic implant. While GnRH agonist and antagonist, they block ovulation and induce hypoestrogenism. Aromatase inhibitors such as letrozole, they reduce androgen aromatization into the estrogen, both in the adipose tissue and within the endometriotic lesions. So we can use OCPs. Even vaginal rings are also available. Patches are also available. Vaginal rings, they are self-inserted. A new vaginal ring every 3 to 4 weeks. And patch, you have to change weekly. So coming on the progestins, these may be oral, may be LNT-IUS, may be Depot, and Dynagest. Oral progestins, these are, progesterone has multiple mechanisms of action that form the pathophysiological basis of its use in endometriosis. What does it cause? It can cause decellularization of endometrium. It inhibits estrogen-induced mitosis, very important. It alters estrogen receptors. It inhibits angiogenesis and the expression of the matrix metalloproteinase needed for the growth of the endometriotic implant, which we all need here. Available in the different form, maybe oral, maybe injectable, maybe intrauterine device. Some of the progestins that have been studied and used in the treatment of endometriosis include sapropterin acetate, Dynagest, dydrogesterone, gestrinone, linezolid, medroxyprogesterone acetate, megestrol, and norethindrone acetate. Many of these we are using in our daily practice. Medroxyprogesterone acetate, also when used injectable, 150 milligram, the name of the DIPA, intramuscular, every 3 months, may be very effective. Although there is no standard oral dose, orally they are available 10 to 100 milligram per day for the 3 to 6 months we are using. Injectable DIMPA, Depot medroxyprogesterone, they have an added advantage of better compliance by avoiding daily administration and the erratic gastrointestinal absorption. If we come on the norethindrone acetate, it is a 19-nor-testosterone derivative and has been proven effective in the control of dyspareunia, dysmenorrhea, pelvic pain, dysphagia, with a better tolerability and less side effect and the lower doses. So Dynagest, a 19-nor-testosterone derivative, is another progestin that is studied in the treatment of endometriosis, and I think that we all are using this most commonly. It is a high specificity for progesterone receptor and less anti-androgenic side effects. Continuous administration led to decellularization and the atrophy of the endometriotic lesions. It also has anti-inflammatory, anti-angiogenic, and anti-proliferative effect. So we should use it, and we are using in the dose of 2 milligram or 4 milligram per day, 2 milligram once a day, or divided doses 2 milligram BD. It comes to be 4 mg. It has shown a very favorable profile for the safety and efficacy. It's generally well tolerated, and side effects still may include irregular bleeding, which improves with time or with addition of the other progestins. LNG-IUS. While oral progesterone have a better side effect profile than the combined hormonal contraceptives, daily administration, the variable serum concentration are some limitations. So LNG-IUS is a better option, and I think we all are happy and have used this device a lot. It contains 52 milligram of levonorgestrel, which releases 20 microgram of the hormone per day over a 5-year of the period. There are many studies The theory behind their success in the women with endometriosis is progesterone-induced atrophy of the endometrium. Which does it cause? It causes hypomenorrhea with possible decreased retrograde menstruation, and the higher concentration of progesterone in the peritoneal cavity thus suppress the activity of ectopic endometrium by its anti-inflammatory and immunomodulatory function. There is also a report of successful use in patients with adenomyosis and even deep rectovaginal endometriosis. Usually it is seen that even post-surgical, when we introduce it in the uterus, it even prevents the recurrence and has a long-lasting effect. Etonogestral implant. How many of us have used it? Another route of progesterone delivery has been studied is the subdermal implant. It's also commonly marketed as Implanon or Nexplanon, as I have shown in the figure. It inserted intradermally in the arm. It contains progestin, etonogestral, and offers contraceptive benefit for 3 years. So, reported rates of improvement in dysmenorrhea in the women using it is a high in carefully selected women who do not desire fertility. Etonogestral implant should be used. Still, more studies are needed on it. Coming on the danazol, long back, there was an era when danazol came into highlight, and we all have used this a long back. It works by inhibiting the pituitary gonadotropin. It is an oral synthetic androgenic steroid. It lowers estrogen and creating a high androgen environment that causes endometrial tissue to atrophy. The common side effects include weight gain, acne, hirsutism, and even voice deepening. As the side effects are mostly associated with oral administration, so alternative routes of danazol like vaginal ring and intrauterine devices are currently in research. I think the studies may come in near future. GnRH analog. This used by so many of us, but they are because of its osteoporotic effects. I think we are using less commonly because it's these effects, they last for, once given, they are in the blood, they last for 1 year. Even after withdrawing, it comes to back. We are using leuprolide. They may be 3.75 milligram depot or 11.25 or Goserlin by the name of Zoladex. The successful use of GnRH agonist is based on the fact that it leads to profound hypoestrogenism by blocking ovarian estrogen production and hence regression of the endometriotic implant. During the first few days of administration, GnRH agonists stimulate the pituitary releasing FSH and LH. However, the chronic administration that leads to downregulation of the pituitary GnRH receptor that result in suppression of the hypothalamic pituitary ovarian axis and leading to anovulation. This eventually led to hypoestrogenism, amenorrhea, and regression of endometriotic implants by depriving the implants of the estrogen that is crucial for their survival. They are the great option for the women who have failed initial therapy with OCPs or are not candidate for the OCPs due to their medical history. So GnRH agonists are available in both nasal and injectable forms and offer high rate of pain relief and longer symptom-free period for up to 12 months. The names I have already taken: leuprolide acetate 3.75 milligram or 11.25 milligram, which is used 3 monthly, Goserlin and Neferlin. The studies show that they are approved for continuous use for only up to 6 months due to concern of the side effect and the secondary to hypoestrogenism like bone loss. There may be severe bone loss in these cases. Maybe vaginal atrophy and the dryness, even hot flashes and abnormalities in the lipid profile has been seen. So addition of add-back therapy provides symptomatic relief, like they may add vitamin D and other add-back therapy. Norethindrone acetate and the progesterone is the only FDA-approved add-back therapy, but low-dose estrogen and a combination of estrogen and progesterone have also been used. Another limitation of the use of GnRH agonists is that they suppress the ovulation and cannot be used in the woman desiring fertility. Coming on the antagonist, elagolix, relugolix, and linzagolix. Now, there is lot much of discussion about these all. They have effect on hypothalamic pituitary ovarian axis, and the only GnRH antagonist developed for fibroid-related heavy menses without add-back estrogen and progesterone is linzagolix. These GnRH antagonists are another group of the drug that have shown promising result in the treatment of endometriosis. Compared to GnRH agonists, they do not cause initial flare and having lower degree of hypoestrogenism and a better side effect profile with equivalent symptomatic improvement. So with a lower degree of hypoestrogenism and better tolerance than the GnRH agonists, they have a great potential in the treatment of endometriosis. So this is a detailed literature about the elagolix. I'm not going to read this all. Relugolix, because nowadays we have lot many lectures on all this elagolix and relugolix. Add-back therapy and the empiric therapy. Add-back therapy has been shown to prevent loss in the bone density and to relieve vasomotor symptom without reducing the efficacy of GnRH regimes. What is Barberry estrogen threshold therapy? It is said that it's better that we keep the estradiol level in the blood between 20 to 50, because below 20, if we keep the level and we suppress the estradiol level too much, then there is an excess of the bone loss, and above 50 there is less effect. Effect is not very proper for the endometriosis. That is the Barberry estrogen threshold theory. Now coming on the selective progesterone receptor modulator, these are relatively new class of agent, and these are ulipristal acetate, mifepristone, RU486, esoprisnil, telapristone, and velaprisone. These cause selective inhibition of endometrial growth without the side effect of hypoestrogenism, decreased menstrual bleeding via effect on the endometrial blood supply, and suppression of the endometrial blood supply are some of the mechanisms that have provoked interest in their use in endometriosis, while they are still on the more study are needed. Aromatase inhibitors. These are third generation aromatase inhibitor which are currently approved by FDA. These are anastrozole, letrozole, exemestane. These are few of the drugs which can be used. Even I have used letrozole in lot many patients and got effect. The scientists have in their many studies are using letrozole along with the other add-back hormone therapy for many months in the case of endometriosis. Newer therapies, they include a chronic medical condition and require long duration therapy. The newer future therapies may be anti-angiogenic factor, may act as a statins, TNF alpha blocker, peroxisome proliferator activated receptor gamma ligands, maybe pentoxifylline, maybe phototherapy. Anti-angiogenic factors, a network of capillaries surround the endometriotic lesion, as we all know. And angiogenesis is a crucial event in the growth and the survival of the lesions. So in the theory, halting the growth of the new blood vessels could stop the growth of the new lesions and regress older ones. So agents like TNP 470, endostatins, Nginx, anti-VEGF antibody like Avastin have been successfully used in decreasing the size of endometriotic lesion in animal model. Human studies are still needed. Statins typically used in treatment of hypercholesterolemia. Their anti-inflammatory, anti-angiogenic, and antioxidant property have provoked interest in their use in endometriosis. Atorvastatin, simvastatin, and lovastatin have been tested in vitro tissues and culture and animal models of the endometriosis. Statin offer another potential therapeutic agent which could be used in the treatment of endometriosis, although more studies are still needed. TNF-alpha blockers. TNF-alpha is a pro-inflammatory cytokine, and its level have been found to be elevated in the peritoneal fluid of women with the endometriosis, with a direct correlation with the stage of the disease. So agents who are targeting TNF-alpha have been successfully used in the treatment of inflammatory conditions like rheumatoid arthritis, Crohn's disease, and now there is an upcoming role in the treatment of endometriosis. Still more studies are needed on its use. Other is the peroxisome proliferator activated receptor gamma ligands. In experimental models, they have been shown to inhibit cell proliferation, increase apoptosis, and inhibit the growth of endometriotic lesion by an effect on angiogenic factor. These are rosiglitazone and pioglitazone. Pentoxifylline, another agent that has been lately studied in treatment of endometriosis. Currently used in the treatment of intermittent claudication, it helps in improving the vascular supply in stenotic arteries by inhibiting the phosphodiesterase enzyme. It also has TNF-alpha blocking property, suppressing the release of inflammatory mediator. Therefore, current evidence still does not support the routine use of pentoxifylline in endometriosis-related pain, because we need more studies and more research is needed. Other very important is the Chinese herbal medicine. These are few medicine which are still in experimental and they are using and claim the great success. Photodynamic therapy is also upcoming branch in this. They put some photodynamic chemical in the peritoneal cavity and the endometriotic tissue, they absorb this, and when phototherapy is given, these particular tissue are being killed up. So I have already talked on endometriosis and defective immune therapy, impaired function of NK cells leading to less cytotoxic NK cell activity in the endometriosis that happens. So impaired natural killer cell activity promotes implantation and progression of endometriotic tissue in the endometrial patients. Very important study of the iron chelators. It is said that in a path-breaking review, potential development of iron in pathogenesis of peritoneal endometriosis is there. So that suggests that in endometriosis patient, iron overload is demonstrated in the different components of the peritoneal cavity. These are the peritoneal fluid, endometriotic lesion, and peritoneum and macrophages. So in these cases, treatment with an iron chelator could thus be beneficial in an endometriotic patient to prevent iron overload and endometriosis. This is a flow diagram, shows how we can add the treatment in case of endometriotic pain. So coming on the prevention, no current method of preventions are known. Some evidence suggests that rapid and aggressive medical or the surgical therapy can arrest progression, especially when the disease is caught in the early stages. Early and prolonged use of OCPs, pregnancy, and breastfeeding seem to afford some degree of protection against the disease. Patient education is very important. Stress to patient, the importance of continuing medical therapy for the full, at least 6-month course. Medical therapy often relieves pain but induces uncomfortable adverse effects. So patient need encouragement. Recurrence of symptoms after therapy should prompt the patient to return for the further evaluation. You should educate the patient regarding severe disease and the symptoms of the bowel and the urethral obstruction. This is a summary. In conclusion, endometriosis cure still eludes us. Significant recurrence have pushed us to explore conservative thought. New treatment modalities will have lesser side effects and the dose control will be possible. Dynogest, that appears to be the best medical option currently, as we all are using. PDT may develop a new method, that is phototherapy, of the treating endometriosis. I think not taking much time, I finish here. Thank you very much for the opportunity. Any questions? I am there. Thank you, sir. And thank you, audience. The patient hearing. Should I stop sharing?
Oh, yes. Chairperson, to conclude the session with closing remarks.
Thanks a lot, ma'am, for such an informative talk. Your session was really very informative and made it clear when to use medical treatment and when to use surgical treatment. Medical treatment is for those patients who are, it can be used for contraception as well as to decrease the disease process. And if after surgical treatment, the disease is progressing, we can use medical treatment. And thank you for all the information. Thanks a lot,
Thank you
ma'am.
very much. Thank you. Thank you, sir, for the opportunity.
Thank you, ma'am.
Thank
And
you. Thank you, Dr.
sir.
Kanchan, for the excellent deliberation and very detailed one at that. And thank you, chairpersons, for being with us. Thank you, Dr. MC Patel, sir, for giving us the opportunity once again to be a part of Happy Learning series. Moving on to the session 2. If there are no further questions, I'll move on to the session 2. Okay. Moving on to the session 2, we now have a talk on surgical management of endometriosis. And to chair this session, we have Dr. Manisha Saxena, madam, we have Dr. Archana Sharma, ma'am, and we have Dr. Neelam Mishra, ma'am. Dr. Manisha Saxena, ma'am, the past secretary of Noida Obs and Gynae Society, is working as a senior consultant at could we have this thing? Mahanandan Super Speciality Hospital, Greater Noida, and Motherland Hospital, Noida. She's been the former consultant at Kailash Hospital and Neuro Institute and Fortis Hospital, Noida. She's been the past secretary of Noida Obs and Gynae Society, member of FOXY Endocrinology Committee 2019, with special interest in high-risk obstetrics, adolescent health, and managing menopause. She's also actively involved in MRCOG teachings and would be a great chairperson for this session. The next chairperson, Dr. Archana Sharma, ma'am. She's been the past president of, could I have the next listing? Of Ghaziabad Obs and Gynae Society. And she has the privilege of starting the first test tube baby center in Ghaziabad. She is at present the medical director, Ganesha Hospital. Please change the slide to Dr. Archana Sharma's CV. She's the medical director, Ganesh Hospital and Test Tube Baby Center at Ghaziabad. She is a consultant IVF and laparoscopic surgeon for more than 36 years and has the privilege of starting the first test tube baby center in Ghaziabad. She's been the recipient of the Dainik Jagran Ayushman Award as well as the Best Fellow Guide Award Nachikon in the field of education. She's been the organizing secretary for a number of conferences, and she's also had presented several papers, presentations in national conferences, as well as participated faculty in many other conferences. The third chairperson, Dr. Neelam Mishra ma'am, is now the president of Isopop Society Kanpur, immediate past president IMA Kanpur, and immediate past president Kanpur Obs and Gynae Society. Her special areas of interest are in minimal access surgery, hysteroscopy, infertility, and menopause, and she's an apt chairperson for this session on surgical management of endometriosis. She's also awarded Nari Shakti, a platinum icon for many contribution to women's health. She's organized multiple workshops, organized panel discussions, been an organizing chairperson of endosurgery. She's been a recipient of Foxy Achiever Award in 2022, as well as the recipient of Endometriosis Warrior Award from Foxy. So you can see she's got immense knowledge on endometriosis, and she's the recipient of Isopop Pillar Award from Isopop Society of India. I'm requesting any of the chairpersons to please introduce the speaker for today. Dr. Pradeep Kakani. I can see Dr. Pradeep here, but I can't see any of the chairpersons. Okay, Dr. Pratik, it gives me immense pleasure to invite Dr. Pratik to speak on surgical management. Yeah, Dr. Archana is there. Yeah. Dr. Archana, yeah.
Dr. Pratik Kakani, it's my privilege to introduce Dr. Pratik Kakani. When he came to Ghaziabad, then he was at my center to join us, and he has joined us also for the endoscopy surgeries. He is a consultant fertility surgeon specializing in the laparoscope and the hysteroscopic gynecological surgery, and currently handling the surgical department at Seeds of Innocence across multiple centers. And he is experienced in fertility enhancing surgeries and endometriosis management, and actively involved in academic trainings and research publication. I'm doing endoscopic surgeries in my center also whenever it is required. Welcome, Dr. Pratik, for the presentation. And now you are invited, and this mic is yours only. Thank you, sir.
Thank you so much. Thank you so much, ma'am, for this beautiful introduction. I'll just share my screen. I'm not able to share my screen.
Now you can, sir.
Okay.
I have made you co-host.
All right. I'm still not getting the. No, it's not showing here.
By the time Dr. Pratik is sharing this slide, I'll thank Dr. MC Patel and the team for inviting me as a chairperson for this particular very important session on surgical management. And I think
you just shared our document. That was yes.
All right.
All right. You could share it.
It was visible.
No, I don't think there is some problem here.
Some net issues.
Some, I don't know, ma'am. It is just not showing here. Even if
3-4
it is.
seconds ago, it was there.
Yeah, exactly. It came, but then it's gone. Sorry, ma'am. You can continue. I'll just figure this out. I'll put my audio on mute.
Simply,
Or
I
you can
wanted
share
to
it
thank
to me.
Dr. Yes, that can also be done.
Yeah, it had time.
You can close and open your PPT again, Dr. Pratik. You minimize this window and check.
So till then, can we shift to another session till Pratik is ready with his
Started.
presentation?
You could start, I think, sir.
Yes,
Sorry,
yes, fine.
sorry,
Fine,
The
fine.
screen is
Welcome.
started, sir.
Welcome, welcome, welcome.
Yes,
Welcome.
welcome, Dr. Pratik, for the presentation. We
Okay.
are having very much eager to listen you.
Thank you so much.
Young, dynamic laparoscopic surgeon working for the endometriosis.
Yes, ma'am. Thank you so much. The first opportunity in Ghaziabad was given by you, and I'm still grateful because it's been a long time. It's been over a year now. I'm practicing in this area. So all thanks to you, ma'am. Okay, so we'll start this short presentation of surgical management of endometriosis. It is presented by me. I have included the ESHRE 22 guidelines, ESGE guidelines, and WES guidelines. So first we'll go with understanding the impact of endometriosis. The disease, presence of endometrial-like tissue outside the uterus causing chronic inflammation is called endometriosis. Global burden, around 10% women of reproductive age group are affected. So you can just imagine how huge the number is. Symptoms are usually dysmenorrhea, dyspareunia, dyschezia, chronic pelvic pain, and the hidden struggle, that is infertility, affects almost 50% of these patients. Endometriosis and infertility, there is a biological barrier because of endometriosis. The most important anatomic distortion because of pelvic adhesions, kissing ovaries, the fallopian tube rotation, and all these factors, the egg is not able to be captured by the tubes, and that's the primary reason for infertility in endometriosis. Second is inflammatory microenvironment. This is a very underestimated factor. Because of the presence of endometriosis, there are a lot of cytokines and oxidative stress in the peritoneal fluid, which impairs sperm motility and embryo quality as well. Also, there is ovarian reserve damage. Long-standing endometriomas, chocolate cysts destroy the healthy ovarian follicles through stretching and inflammatory infiltration. Also, it affects the endometrial receptivity. This is most commonly seen in infertility patients because they are going through ART, and many a times the small chocolate cysts or peritoneal implants are left as it is because of difficulty in operating and all, and they undergo multiple cycles of embryo transfer, which eventually results in failure with no apparent cause. So endometriosis is an important cause in such patients as well. Now, general surgical principles based on ESHRE 2022 guidelines. First is indication. Surgery is recommended for pain relief when medical treatment fails or is contraindicated. The one-stop shop, that is clinicians should perform a thorough visual inspection of entire pelvis to identify all types of lesions, that is superficial, ovarian, or deep. Laparoscopy is still the gold standard approach. It offers better magnification and faster recovery than open surgery. Biopsy, always any suspected lesion, even if it is a small fibrotic nodule somewhere, that should be taken for biopsy and sent for histological examination, because only then endometriosis can be confirmed. We can see these endometriotic implants, vacuum seal sign, that is peritoneal defect, also, and these small implants and vacuum seal sign, what we see, this is a damaged endometrium and should be removed. Now let's talk about ovarian endometrioma management. We can see such big endometriomas usually present, and after a good surgery, removal of this endometrioma and the small peritoneal deposits, we have also experienced the patients have conceived right in the next month after the surgery. So cystectomy and drainage have always been contradicting points, and but the recent evidence has shown that cystectomy is definitely superior to simple drainage or ablation, because as long as the cyst wall is present, even in a couple of months, it can secrete the reactive fluid, and the cyst will be formed again in less than 3 months. Lower recurrence rates and better pain relief with cystectomy, definitely. Cystectomy also increases the rate of spontaneous pregnancies compared to drainage. Like I said in the previous slide, I have shown the endometrioma that we had performed cystectomy, that patient actually conceived in the next month. Surgery can reduce the ovarian reserve. This is a risk factor, but compared to the advantages, I think cystectomy still should be performed despite the risk of ovarian damage. Now, how can we protect the ovarian reserve? Hemostasis matters. So while operating, we make sure that we use very minimal energy, and we completely avoid using any kind of energy near the ovarian hilum, that is the anterolateral part of the ovary, because that is where the maximum blood supply of the ovary comes to. If a lot of energy is used there, that damages damages the entire ovary and decreases the reserve very significantly. We prefer using sutures or hemostatic sealants to control bleeding without burning the healthy follicles. We should always keep in mind while operating that there are good primordial follicles present in that ovary, which will eventually determine her AMH levels or her ovarian reserve, and we should try to conserve them as much as possible. Any large cyst more than 5 cm, surgery is definitely recommended to reduce the risk of ovarian torsion or rupture, and also access to follicles during IVF. In case of pickups, it is usually difficult in cases of big endometriomas, because if the needle punctures the endometrioma and then goes to the follicle, that inflammatory fluid has come into your aspirate. So the quality of eggs is going to be deteriorated after that. Now about deep endometriosis and mapping. This is very important, and especially in mild cases, if she's undergoing laparoscopy for some other reason as well, I feel this should be performed in all the cases, because diagnosing and treating endometriosis early is the best way to manage it. So any lesion which infiltrate more than 5 mm under the peritoneum is considered as deep endometriosis. Preoperative mapping can be done with a good transvaginal ultrasound or MRI. We typically identify the involvement of uterosacral ligaments, rectovaginal septum, bowel, bladder, ureters, and the entire pelvis. The Enzian classification is used in laparoscopy, after laparoscopy, because this is the only classification where visual inspection of the pelvis is categorically defined and can be a good documenting tool. So this is one case of mild endometriosis. We had just posted her for diagnostic laparoscopy. As you can see in the first image, the appendix is adherent to the lateral pelvic wall near the IP ligament. In the second image, the left fallopian tube is adherent, and also the sigmoid is convergent over the pelvic wall, over the bifurcation of iliac arteries. Then we can see small powder burn lesions in the third image in the ovarian fossa, and we can see some red colored lesions on the right uterosacral. So these are as Kanchan ma'am had mentioned in her presentation, how to identify the lesion. All the 4 categories can be very nicely seen in this one. Now, this is a typical picture of frozen pelvis, which is deep infiltrating endometriosis. As you can see, the uterus, left fallopian tube and ovary and the bowel are completely adherent, and we are not able to see the entire pelvis here. In these cases, it is better to start dissection from a free plane, from a disease-free plane, and then slowly approach the area where there are dense adhesion instead of attacking the adhesions directly. Now, surgical techniques for bowel involvement that we use. First is shaving. If the mucosa of the bowel is not involved and only superficially it is involved, then we shave that lesion without opening the bowel. Then there is discoid resection, where the complete circular excision of the bowel wall where the lesion is located is done. For this, we use staplers. Staplers are very good, very safe to use, and very easy to learn. Not very difficult, because in resection and anastomosis, a lot of it is difficult to learn and has a very steep learning curve. And then there is segmental resection, the removal of the full segment of the bowel followed by anastomosis. This is for large and multiple lesions if there are in the bowel, usually at the rectum, rectosigmoid junction and everything. If all of that is involved, sorry? So we'll continue the presentation to surgical techniques, involvement of the urinary tract. So in urinary tract,
Very good.
deep endometriosis can cause silent kidney damage. The ureters, if the ureters are involved, so first thing is we do ureterolysis in almost all the cases wherever we are opening the retroperitoneum. Ureterolysis is basically freeing the ureter from the fibrotic tissue. So ureterolysis, we start at the pelvic brim and we slowly enter in the Wertheim's canal, where the ureter is entering the broad ligament. Then in cases where the ureter walls are involved, we do ureteral resection. That is, we cut that portion and then stitch the healthy portion back. If the bladder is involved, partial cystectomy is the only way. We remove the affected part of the bladder wall, and then that is very effective in pain and frequency symptoms as well. So this is a small superficial bladder nodule that we had. If you can see a powder burned lesion right in front of the grasper. Now, role of the skilled surgeon, this is very important, because as long as because many people do not attempt endometriosis, I feel, because they are not confident in entering the planes and how deep the involvement might be. So a good surgery is defined by precision, not just speed. Complete clearance is important. A skilled surgeon identifies the occult and clear lesions that others might miss, reducing the need for repeat surgeries. The most commonly endometriosis patients undergo 3, 4, 5 surgeries, and mostly it is because of these small features that are missed, that do not probably require that high surgical skill, but diagnosing skill. Then nerve preservation is very important, because if the hypogastric nerve or genitofemoral nerve are damaged during your dissection, that is going to cause post-operative bladder dysfunction, loss of sensation, and other lifestyle issues to the patient. So we must keep in mind that endometriotic surgeries are mainly lifestyle related. If for treating that we create another lifestyle issue, that is not going to solve the problem. Then tissue respect, minimizing thermal damage near ovaries, tubes, maximize the patient's future window of fertility. multidisciplinary team. Best outcome occur only at high volume centers where gynecologists work alongside colorectal and urological surgeons. So having the good team is the only way to approach endometriosis, because many a times in the areas where we might not feel, as gynecologists, we might not feel very confident or very happy operating, it is better to involve a colorectal surgeon or a urological surgeon and work as a team to cure the disease. So this is the post-operative picture of the ovarian endometrioma and the bladder nodule. As you can see, we opened the UV fold area and we have removed the bladder nodule completely, and the ovarian endometrioma is also drained and sutured. So this was another case that I had shown where there were multiple deposits, powder burn lesions and red implants at the uterosacral and ovarian fossa. Here we have done butterfly peritonectomy. We have removed all the implants, all the unhealthy peritoneum, and preserved her reproductive function. Now, post-operative management, hormonal suppression is definitely recommended. LNG-IUS in case the patient does not want fertility in the near future, or OC pills for at least 6 months to reduce the risk of endometrioma, or we can also use leuprolide, because that causes good hormonal suppression for 1 to 3 months, so that can also be used. Now, fertility follow-up, if the patient wants to conceive, they should be encouraged to try soon after surgery. That is the golden window. The golden window is usually 3 to 6 months after a endometriosis surgery, where the patient has maximum chances of conception. Need of ART, if pain persists, fertility doesn't happen, ART should be considered promptly, or if the ovarian reserve is less, so in those cases, definitely ART should be recommended. So conclusion and take-home messages: individualized care, tailor the surgery to patient-specific goals, that is pain versus fertility. If the patient wants to get operated for pain, the surgery should be focused on removing the entire diseased area. While for fertility, we should try to conserve the reproductive organs, which will help her achieve normal pregnancy. Attack the disease. One comprehensive expert surgery is better than multiple incomplete procedures. Protect the reserve. Always operate with primordial follicles in mind. And excision is the key. Total excision of lesions is the gold standard for long-term recovery. Ablation and all those things that were tried in the past do not work, because in the picture of bladder nodule that I had shown, in that case as well, the powder burnt lesion was very small. But as we started opening it, it was very deeply involving the UV fold, the uterovesical fold area. So when we started opening, that is when the tip of the iceberg was exposed, and we could remove the entire nodule in that case. So thank you, and any questions are welcome. I'll be happy to answer.
Ma'am, over to the chairpersons for their concluding remarks, please.
Archana ma'am, could you please unmute yourself? I can't see any other chairperson.
Sir, can you stop sharing the screen?
Yeah, sure.
Excellent talk. I'm Dr. Radna. Hi, everyone.
Hello,
Dr.
ma'am.
Pratik, excellent presentation. I think you have explained the basic guidelines very well about the surgical management.
Thank you, ma'am. Thank you.
Thank you, Dr. Pratik, for the deliberations and knowledge enhancement on surgical management of endometriosis. I now hand over to the third coordinator for the series for for session 3.
Thank you, Dr. Nivedita. Tech team, can we have the CV slides, please? Moving on to the last talk by none other than Dr. MC Patel, sir. I take privilege in introducing our chairperson, Dr. Alpana Agarwal, Madam, Professor and Medical Superintendent at Santosh Medical College Hospital, Ghaziabad. She has received various special awards to her credit, and she has a past teaching experience of 26 years. She has been also awarded the Corona Warrior Award by IMA Ghaziabad and the Global Teacher Award in 2021. She is the Organizing Secretary of the UPCOG 2020. We welcome you, ma'am. Our next chairperson is Dr. Kanchanjala Gupta. She is the Director of Ashirwad Clinic and Maternity Center at Kanpur. We welcome you, ma'am.
Good evening.
Our next chairperson is Dr. Archana Mehta. She is the Professor and Head of the Department at Sharda Hospital at Sharda University at Greater Noida. She is also the President of the Greater Noida OBGYN Society. She has a teaching experience of more than 18 years. And she has various publications to her credit. I welcome all the chairpersons and request you to please introduce our speaker, Dr. MC Patel, sir, for today. Archana ma'am, the CV is displayed. If you could please introduce.
Am I audible?
Yes,
Good evening. Yeah. Oh, it gives me pleasure and privilege to invite Dr. MC Patel, sir. At the outset, I would like to thank sir and his team for giving opportunity to me to represent Greater Noida Obs and Gynae Society in this Happy Learning Masterclass. Sir needs no introduction. So, but still, I would like to give his official introduction. He is well-known obstetrician and medico-legal counselor and great advocate of doctor safety. He has held many prestigious positions in FOGSI and many societies and has authored medico-legal issues in FOGSI Focus and contributed to the creation of uniform consent document for national use. Sir has delivered many deliberations and conducted many panels at state level and national conferences on medico-legal aspects. So, sir is going to enlighten us on medico-legal issues on endometriosis. Before his insightful deliberation, I would like to enlighten everyone that we all know that we gynecologists are at the risk of litigations. And now I think we are living in the era of evidence-based practice. But I feel that we have to do safe practice if we follow evidence-based practice as well as defensive practice. Defensive practice doesn't mean that we are anti-patients. But, we have to have both clinical knowledge and legal knowledge. I think these are two important pillars of nowadays practice. I would just like to quote an example that our clinical knowledge is like an engine and our legal knowledge is like brake of a car. So we are driving our car with engine, that is with clinical knowledge, and we are holding the patient to our healthy status. And with the help of our legal knowledge, that is our brake, we are making this journey a safe journey to prevent crash. So, sir is there to enlighten us because he has vast experience on this medico-legal issues. And so I think we have to follow this evidence-based practice and defensive practice because this legal knowledge is going to shield us. So over to you, sir. We are so eager to listen to your insightful talk. We welcome you, sir.
Thank you, madam, for kind words, and please allow me to share my screen. Is it seen?
So it is just started sharing.
Yes.
Now it is seen, sir.
So is it full screen?
Not yet, sir.
Not yet. Again, the same problem which we faced in past also. Give 1 minute. stop sharing again to share. Now, is it full screen?
Yes, sir.
Full screen.
Yes, sir.
Yes, fine. So, greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. So, warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the president and secretary of respective societies who have joined this webinar and all the delegates. I also thank you all because during my last election, Foxy, you all stood with me just like a rock, though I lost. But I believe in this. This is very nicely written by Shraddha Atal Bihari Vajpayee, and I was lucky to work under him for some time. क्या हार में क्या जीत में किंचित नहीं भयभीत में कर्तव्य के पथ पर जो भी मिला ये भी सही वो भी सही. So loss is not the end but new beginning, and journey to serve Foxy is still continued with renewed patience. And my commitment is still there. Wherever you are, I'll be there. Promise to reach the unreached in any odd medico-legal situation. Minimizing litigation in management of endometriosis is my today's topic. But before I go to that topic, I seek your blessings and support for my candidature for President Foxy election year 2026. So from clinic to courtroom. Is it worth discussing? I usually start any of my talk with this question. Yes. And if it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first as far as all these medical legal issues are concerned, whether it is civil suit, whether it is in CPA, whether it is criminal case, Human Rights Commission, MCI or NMC or at government level, but we gynecologists in a driving seat. And ignorance of law is no excuse, because as soon as any law, any ordinance, any act passes in government gazette, it is presumed by law that each and every citizen of India knows that law. So ignorance of law can never be an excuse. And we are working in this era. As such, I have searched in Google about my illness and medicine, etc. But thought, let me have a second opinion from you. So we are working in this area, and a patient is smart enough. They come with some, of course, incomplete information, I would say, through Google, and it could be troublesome for us to convince them in many of the conditions, many of the time. We take utmost care of any of our patients, whether it is a medical management of endometriosis or it is surgical management of endometriosis. But we never know. Accident may happen at any time. And once accident happens, then it becomes a potential area as far as litigation is concerned. And we have to observe this also. We have to treat patient. We have to satisfy relative. And at the same time, we have to save our own cap. This is our clinical practice. And which are the areas for litigation in management of endometriosis? Most common allegations usually we face as far as diagnosis is concerned. And rightly mentioned by Dr. Kanchan also, in many of the patients, we miss the diagnosis well in time, and average time she mentioned about some 8 years or so. So it is very common allegation nowadays, delayed in diagnosis, investigation or treatment, or missed diagnosis, investigation or treatment, and wrong diagnosis. It is also one more allegation nowadays as far as treatment of endometriosis cases are concerned. One more area is complications, complications of treatment, medical management when we are going for, then side effect of medicine is one part as far as this allegation is concerned. And as far as surgical part is concerned, it is a very common condition. Whenever something goes wrong in surgical management, it becomes an area for litigation. But very important question, can surgical management of endometriosis be considered as a fertility enhancing surgery? Of course, there are so many cases where with laparoscopy, endoscopy, we can enhance fertility possibility, but it is not always there. Many a time patient is much more concerned about her pelvic pain. So we should be very clear, rightly mentioned by Dr. Pratik also, we should be very clear at the time of our management, and it should be well explained to the patient what we are going to do and how it will be beneficial as far as her fertility part is concerned. So as far as this surgical part is concerned, these are the areas where we may end up into litigation. Unexpected result during surgical management, that is failure of procedure or operation, trauma or injury, hemorrhage, infection, and complication of anesthesia. These are the common area where we may face litigation in management of surgical management of endometriosis. An injury to surrounding structure is a very common allegation and very common condition, because when there is a deep-seated endometrial nodule, then it is all likely that we may injure surrounding structure and we may end up into litigation, either injury to vessels or ureter or urinary bladder or bowel. It is very common complication when we are dealing with surgical management. But whenever we are facing this litigation, as far as any injury to surrounding structure is concerned, this very common question we have to face, was it preventable? And usually you cannot say no. And if it is yes, then one more question will be asked, what did you do to prevent it? So in our surgical note, we should be very clear that how we have managed that very case surgically. And if we have video recording, and if we are going to give recording to the patient, it should be well edited, not to end up into any problem through that video recording also. And if at all you couldn't prevent and some complications happen or injury to surrounding structure happens, then a very important question will be this, why you couldn't prevent it. So we will have to explain why this happened, and in spite of all our care and caution, why we couldn't prevent it. But very important part, if at all it ended into any injury to any surrounding structure, then did you diagnose well in time is very important, because many a time when there is a thermal injury to bowel, many time at that point of time we may miss the diagnosis, and after 36 or 48 hours there is sloughing out of that burn area, and there could be a fistula, and patient may end up into complication. So this is very important part. Did you diagnose in time? And very important part is, did you manage that complication way in which any prudent doctor would have managed in that very given situation? So if you can answer all those questions, then in spite of you ended into injury to surrounding structure, then also you could be out of problem as far as litigation part is concerned. But these are the known complications of any surgical treatment as far as endometriosis management is concerned. One more area for litigation is recurrence. And we know this is very common, and reoccurrence of pain or any other problem, including infertility, is very much known. And this is a common allegation, no proper care taken to avoid reoccurrence. Again, all this set of questions just we discussed, we will have to face. Record not provided. Many a time, this is also one more allegation. If patient has asked for record and if you have refused, because as per guideline from MCI, we are under obligation to provide record within 72 hours. And as per guideline by NMC, within 5 working days, we are under obligation to provide record to the patient or near relative of patient. Or in that very case, when patient has given authority to any other person to collect record, we are bound to give record to that very person. One more area nowadays, tremendous expense against unexpected result. If we have mentioned that it is to enhance fertility profile in future, and patient is not getting pregnancy in due course, then this could be one more area that it was tremendous expense, and a result was expected that she should go with pregnancy, and she is not getting result. So these are the areas as far as litigation is concerned. So every case of endometriosis, it is a potential threat as far as litigation part is concerned. And treating serious patient could be suicide. Just like if it is a deep-seated nodule either on sigmoid colon or bowel or at any other place, it is all likely that you may end up into some complication. And in this type of situation, it is all likely that you may end up into litigation, and you are bombarded with so many questions when something goes wrong. Who is responsible for this? Why this happened? Where were you? Why you couldn't prevent it? So there are so many questions we have to face whenever we meet any complication. So what to do and how to prevent all this problem? So there are only three parts you have to observe: foreseeability, anticipation, good communication and consent, and proper documentation, and you will be simply sailed through. As far as foreseeability or anticipation is concerned, court and law expect from us to anticipate certain complication and procedure, and we should be readily available to deal with situation. Say for example, just I mentioned about deep-seated nodule on sigmoid colon. So we should anticipate that we may injure sigmoid colon, and colostomy may be required in that very session, or we have to ship patient to another center for the same. So we have to anticipate, and we should be readily available to deal with situation. Let us see this very important case, and we will discuss further. So in that very case, it was severe dysmenorrhea, infertility, deep-seated endometrial nodule on sigmoid colon, advised laparoscopic excision, injury to sigmoid colon during surgery, colostomy was done. Second surgery to close colostomy and anastomosis was required, and case was filed in this particular case. Compensation was demanded 11 crores in this particular case, but court didn't allow that, but court allowed 42 lakhs of rupees as a compensation in this particular case. So where things went wrong, and where in this type of situation we end up into litigation. So just I was discussing about that when it is deep-seated on sigmoid colon, naturally we should anticipate that it is all likely that we may injure sigmoid colon. But if at all it happens, then what will we will be done? So not anticipated or not prepared to manage that very complication is very common allegation in this type of situation. So very important part, prosecution could be smart enough to ask this type of question. As far as bowel preparation is concerned, in this type of cases, when we are dealing with a deep-seated lesion on bowel, yes or no, naturally we have to manage that patient accordingly. Discuss with gastrosurgeon before you are going for surgery for that very case, that if at all there is something goes wrong, then are you available to join me? And this type of preparation, or have a phone call to gastrosurgeon nearby, it shows your concern that you have taken utmost care of your patient in that very given situation, if at all it happens to deal with the situation accordingly. Will call gastrosurgeon at your hospital, or will you refer that very patient to his hospital? So it is up to you in that very given situation. If you have well set up to deal with all this situation about, say for example, colostomy or so, then you can very well call gastrosurgeon at your place, and you can very well deal with the situation accordingly. Or you can refer patient in that very situation to any other center. Again, the same set of questions just we discussed prior, we will have to face. Was it preventable? Yes. Then what did you do to prevent it? Why you couldn't prevent it? Did you diagnose in time? And did you manage way in which any prudent doctor would have managed? So this is part of management involving gastrosurgeon or gastrolepro in this type of situation. So very important question. Would you like to involve other colleague or would you like to treat alone? Not for complication only, but even for any surgery related to endometriosis surgical management part is concerned. So if you are competent enough, naturally you can go alone. But just I mentioned, you should have a phone call to urologist, to bowel, gastrosurgeon. If at all need of them requires, then they should be ready to join you in the surgery. So involve professional colleague, preferably since beginning, whenever you are dealing with a very serious case, serious in the sense deep-seated this endometriotic patches, etc. So in this situation, it is always better to go with joint venture because balanced teamwork is always beneficial, not to the patient only, but to us also, because it shows our concern to take utmost care of patient. No consent taken. One more area as far as litigation is concerned, or no proper consent taken is many a time allegation. We were not explained about possibility of this type of injury to surrounding structure, etc. This could be a very common allegation in this situation. One more area, would you give guarantee as far as result of your surgical management of endometriosis is concerned? Because no rosy picture or no tall claim about your result, because when you claim to be master in eye of law, you are supposed to be master. And in our practice, surgical management or any medical management of endometriosis, we consider result like Aishwarya Rai, but it may turn like this at any time. So no tall claim, no rosy picture about result. Would you advocate post-operative counseling also? Always yes. It is always better to go for post-operative. Even if surgery has gone smooth, then also you should have a word with a patient if patient is comfortable. Otherwise, to the relative that what was the problem, what you have done, and what is now your suggestion or instruction to the patient and patient relative about medicine to be taken, diet to be taken, exercise. If at all any reference is required, then reference of professional colleague. So we have to instruct all this after surgery, and this is very important counseling part in this situation. Because in this very famous case of C. Jaipal Reddy versus Padmini Veluri, court was very clear. It was decided in National Commission, and National Commission was very clear that consent is not mere piece of paper where patient or patient party has to sign, but it is very important document of your communication, of your counseling, of your communication. Whatever you have counseled, whatever you have communicated to the patient and patient party, each and every point should be mentioned in consent paper. And once patient sign the document or patient party signs the document, it becomes documentation of your communication. So as such, consent is a documentation of your communication. So who can give consent in this type of cases? Naturally, when patient is adult, when patient is mentally sound, only and only patient can give consent. All other relatives are witnesses only. If patient is minor, then or mentally challenged, then guardian may give consent. Can minor give consent for examination? Many times minor may be presented to you with chronic pelvic pain or case of endometriosis. Of course, it is less in number, but if at all it happens, then if in this type of situation, can minor give consent for examination? Yes. If she is more than 12 years, even though she is minor, then also she can give consent for examination. But as far as surgical interference is concerned, then she cannot give consent for surgery or procedure. And in this situation, consent for guardian is required. Can visually challenge give consent? Of course, yes. If she can listen you properly, you can explain everything. And after understanding this, if at all she have any question, she can ask. And if you can solve her query, then she can give consent. But word of caution, there should be one guardian or witness, then he will sign the document. Before me, it was explained to the patient, and then after patient will sign the document. Can the offender give a consent? Of course, yes, again, if she can read, then you can give paper to read her. And if she can go through, and if at all she have any query or question, she can ask and she can sign the document. But again, in this case also, one guardian will sign as a witness, because if at all, then she will write like this: before me, it was explained to the patient, and patient has signed the document. Can we allow attendee at the time of surgery of endometriosis, or can we record, or can we display in workshop or in CME or in conferences, etc.? In all those conditions, prior consent of patient is very much must. And whenever we are going to display, then personal identity of patient should not be revealed, and we should be very careful about the same. But in all this situation, records are always at your rescue, so keep them up to date. What was done, nothing was neglected. Given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court. Important bills are also part of your record, and it is very important document. Many times it may save you in court of law. Say, for example, purchase of oxygen cylinder or nitrous or any other gas you use in your endoscopic surgery, defibrillator, ventilator, emergency instrument like ambu bag, emergency drugs. Because in this particular case, allegation to us was that when patients suffered heart attack, oxygen cylinder were empty, and we were saved in this particular case only due to bill of refilling of oxygen cylinder. So bill of refilling of oxygen cylinder is also important document in your record, and it should be there. And refilling of any other gases, nitrous or any other gases we use in endoscopic approach. Transfer of patient. Many times, if at all we have to transfer patient to higher center, then it should be in time at proper hospital and confirm availability of bed, ventilator, OT, and blood, etc. at that very center where you are referring to a patient, and with proper person you have to inquire about all this, because many a time patient is in a serious condition and patient require ventilatory support, and in that very hospital ventilator is not available, and patient will have to be shifted to another hospital, and precious time is wasted. One more area, escort in the same ambulance whenever you are escorting the patient. Handing over of the patient to the proper and right person, and note the time and date when you have handed over patient, and all transfer document you have to give to the patient and patient party. I don't want to go into detail, but all this is a list of this checklist, which kind of document you have to be you have to give to the patient at the time of transferring the patient, and preserve all the transfer notes or document you have given to the patient at the time of transferring the patient. But you have not to worry. You have to simply visit Foxy Uniform Consent, and on Foxy website it is available with 3 medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared 30 different consent, and in those very consent, surgical approach and endoscopically, we have prepared separate consent for the same. You can use that. And at the time of transferring the patient, how consent is to be taken, how document is to be, and which document is to be given to the patient and patient party, we have mentioned all those in that very consent. So there is always a way. There is nothing to worry about all these probable complications or litigation parties concerned, but remain alert every time. Otherwise, be ready to face this type of situation, because this gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. There are so many cases decided in Supreme Court, in National Commission, in Honorable High Courts in our favor as far as management of endometriosis or any other obstetric or gynec emergency cases are concerned. But we should be aware of those judgments in our favor, because in our practice, we know medicine is science of uncertainty and art of probability. And the problem with world is that intelligent people are full of doubts, while stupid ones are full of confidence. So we should decide where we are. And if you want to sleep like this, take tender care of your patient. Pray Almighty God before going to sleep, and keep my visiting card below your pillow, because I am always there to assist you in any odd medical legal situation. So all the best. God bless you. Have a litigation-free medical practice. With regards, and before I end, please endorse my candidature for post of President Foxy, election year 2026. All the president and secretary are requested to nominate my candidature. You will get communication from Foxy in last week of April or first week of May. First, you will have to endorse my candidature, and then in month of August 1 to 10, you will have to vote for me, and you will make others also to vote for me. Thank you very much. Salute to all, and please do not assume. Please ask if any query, any questions, if chairpersons and time permits. Thank you very much.
Thank you, sir. Excellent guidance by Dr. MC Patel, sir, as ever. As sir told, gynecologists are trapped first in medical litigations. So be cautious, and early evaluation symptoms must be done to avoid delayed, missed or wrong diagnosis. Proper differential diagnosis must be done. Detailed informed consent as told by sir. Referral whenever needed. Proper documentation records are must, and multidisciplinary approach must be followed. And recurrences, for the recurrences, we must explain properly to the patients, as well as told by sir, high expenses are there and unexpected results are there. So we must be very much cautious. And sir, also one more point, I am very junior to you, as endometriosis is also a disability and is under the Equity Act 2010. Thank you, sir. Very excellent, sir, talk. And we are always guided. Thank you, sir.
So at the time of counseling, we have to counsel patient with all the details, which are the possibility as far as result is concerned, as far as probable complication related to this treatment protocol is concerned. And if we have explained everything in detail to the patient and patient party, then it becomes easier to face. If at all we end into any complication, then also it is easier to face this situation if we have explained in prior.
Thank you, sir.
Any comments from any other chairpersons or guests?
Thank you so much. Thank you so much, sir. And our best wishes for your upcoming elections for the post of president.
Thank you, ma'am. So, any other comments from Gulati sir? Yes, thank you, sir. Yes, then we can switch over to next session.
Thank you so much, sir. Once again, another enlightening session by sir. I am finding it difficult to find adjectives for sir each time that I have to conclude his talk. Thank you so much, sir. We will move on to a panel discussion. We have a very pertinent panel discussion today. We will be discussing some cases in the management of endometriosis. We have Dr. Aradhana ma'am and Dr. Jigyasa ma'am as our moderators, with Dr. Sanchita Dubey ma'am as our expert. Dr. Aradhana ma'am is the past president of Noida Obs-Gynae Society and a gynae laparoscopic and robotic surgeon. Also additional director in Fortis Hospital, Noida. Welcome, ma'am. Our other moderator is Dr. Jigyasa Govil ma'am. Ma'am is the vice president of the Noida Obs-Gynae Society and a consultant at Cloud9 Hospital, Noida and God City. Welcome, ma'am. We have Dr. Sanchita Dubey ma'am as our expert for the day. Ma'am is a senior consultant in Apollo Hospital, Noida, as well as the director of Evidence Healthcare Clinic, Noida, and the president of the Noida Obs-Gynae Society. Welcome, ma'am. We have 9 panelists from across North Zone with us today. Our first panelist is Dr. Mithi Bhanot, ma'am. Ma'am is a senior consultant in Apollo Hospital, Noida. She is the current secretary of the Noida Obs-Gynae Society and has been the past joint secretary. Welcome, Dr. Mithi. Next, we have with us Dr. Shweta Mathur, ma'am. Dr. Shweta Mathur is a consultant obstetrician and gynecologist as well as a sonologist at Srijan Clinic in Noida. She has special interest in gynae ultrasound and hysteroscopy and has been the past secretary and treasurer of the Noida.
I think she has lost communication. So any other coordinator can take over. Monica, Deepika, anybody?
I think I'll take over. And Dr. Aradhana, thank you, sir. Good evening for giving
Yes.
the opportunity. So,
Please.
Dr. Manisha Agarwal is she's a trained laparoscopic surgeon, a senior gynecologist, professor, head OBG, and at Dr. KNS Memorial Institute of Medical Sciences, and has many awards to her credit. Next, please. Then Dr. Reshma Nigam, she is the infertility and high-risk pregnancy specialist, honorary secretary, Kanpur Obs-Gynae Society, and she has had various positions held at Kanpur and many publications, and she's a member of many reputed organizations. Next, please. Dr. Ritu Mittal Arya is our known gynecologist from KMOG. She's Obs and Gynae senior consultant at Yashoda Hospital Cloud9 and Max Hospital Ghaziabad. And she was secretary of KMOG's president's 3 IMA West Ghaziabad, very active members with very many awards to her credit. Welcome, Dr. Ritu. Next. Dr. Samta is, she's a senior consultant professor OBG and a very active member of from Greater Noida Society. And she was the scientific secretary of, she is the scientific secretary of Greater Noida OBG Society. And she has various awards and recognitions. Welcome, Dr. Samta. Dr. Gunjan is a very senior infertility specialist and very promising member from KMOGS, and she is the she has advanced diploma in reproductive medicine and executive member of Infertility Committee FOXI Certified Center for IVF Training and Fellowship. And she has various publications and various awards and achievements to her credit. Welcome, Dr. Gunjan. Next is Dr. Apurva Asthana. She is the Director, Phoenix Healthcare, Greater Noida, and consultant at Cloud9 Hospital, Greater Noida, Yatharth Hospital, Greater Noida. She is the Secretary of Greater Noida OBG Society. Welcome, Dr. Apurva. And then Dr. Vani is the Senior Consultant at Cloud9 Hospital, Indrapuram, Ghaziabad. And Dr. Vani's Women's Wellness Clinic. She has various positions and achievements. She was the Finance Secretary of IMA, UP, State Coordinator of Mission Neve, PPH, and National North Zone Coordinator of FOXI. Welcome, Dr. Vani. So I think I can share. I'm Dr. Aradhana Singh. Along with Dr. Jigyasa, we want to thank Dr. MC Patel sir for giving us this opportunity for this excellent, webinar, making us part of this excellent webinar. And thank you, sir. It is always listening, great listening to your lectures. So I would like to share my presentation from where I can share, if somebody allows me to share.
No, at bottom, green button.
Yeah, share. Yeah, share. I'm going
Yeah.
there. And content screens. Am I given permission to that?
Nilesh,
Should I share? Made you co-host.
Should
So
I
you
share?
can share.
Just a minute. Let me just try once more. Otherwise, you share. It's not showing on my laptop. Share. It's not. Jigyasa, you can share
Yeah,
maybe,
I'll try to share.
because the content is not shown.
Are you able to see?
No, ma'am.
We are not able to see our files actually in this documents.
You have to open it first, ma'am.
Aradhna madam, first you be ready with your presentation.
So it is already opened, but I'm not
Be
able to
open.
see here.
Then it should open. At the bottom, you go with this button, share. Click it.
So,
Yes.
Yes, it's coming.
Dr.
Okay,
Jigyasa.
loading.
Just a second.
Now you go to your presentation.
Open your presentation, Aradhna.
See, I have opened. I am not able to see where it is.
The bottom where you have audio, video, there is one share button there.
It is not seen. Jigyasa, can you do it? Or I will share the presentation in the group. Somebody else can share.
Can you see it now?
No, madam. We
No.
cannot see. You can share it in group.
I am sharing just
share button.
Because you are the admin.
I am not the admin.
Admin कौन है?
Go out of the screen, please. The organizer can check if she has the right to share.
Yeah,
Yes, ma'am. I
Jigyasa,
You have to make her
made
co-host.
them co-host. I have made them co-host.
She is already co-host, so it is not an issue. But be ready with your presentation, minimize it and go with sharing. That it should open.
It is actually earlier it used to show all my presentations, but it is not showing this time.
No.
I will.
I have shared one screenshot in group
Share.
also.
You
that how
can.
to share.
You can, Aradhna, you can see this share button, the green button at the bottom.
I can see, but I cannot see where my files are.
So you open it on the screen first.
Just a minute.
And then share.
Documents, screens.
Open your presentation and then share.
I am not able to see. Jigyasa?
Yeah, I'm trying to.
Sanchita, I've sent it to you. Can you see it?
All right. You have mailed me or what?
WhatsApp.
Acha.
Or I'm
Okay.
giving it in the group.
All right. I'll see.
10th. So it's in the group if somebody can.
Nilesh, you can do that.
Yes, sir. But
It's coming
I
there.
think it is on the way. Yes.
It
I
has
got
already gone.
Yeah, I'm downloading it.
Yeah. It's not actually visible in my this thing. Notes is opening. Probably some setting change has happened in this.
Might be. Just a second. I have downloaded it.
I think there is some problem because share मेरे से भी नहीं हो रहा है. It's showing
Ah,
that
Is it
you are
visible?
sharing the screen.
Anyways, so it has come. So we'll be asking you to change the slides. Okay.
Yes, ma'am. I will be
Yeah.
doing that.
So thank you. So so now we are sorry for this. I don't know why it is not being shared by anybody, and it's fine. So we are here. Now who is doing this? Already shared. Don't do anything now.
I'm doing it. I'm doing it.
Okay, okay.
Open the
Just say-
presentation, please.
Sorry, ma'am?
So I think a
Yeah.
lot has been discussed about the panel already. We know the medical management, we know the surgical management and the medical legal aspects now. But now we are coming to the clinics, the clinical aspects, the case-based discussion of this management of endometriosis, that when patient is sitting in front of us, how we are going to manage. So next, please. So I am Dr. Aradhana Singh along with Dr. Jigyasa and expert Dr. Sanchita, and the esteemed panelists already been introduced and welcomed, and we are going to discuss about the cases. Next, please. Next again, it is actually on the, you have to click, yeah. So endometriosis is a disease in which the tissue similar to the lining of the uterus grows outside the uterus. We all know the implants grow and invade the tissue in their vicinity, causing inflammatory reactions. So chronic inflammatory disease, chronic painful condition, and it all negatively affects the quality of life. Next. So according to the WHO, the global prevalence of endometriosis is 10% of the reproductive age women and the girls globally. And Asian women are reported to have higher prevalence of endometriosis and higher frequency of moderate to severe endometriosis. Next, please. So it is the missed disease. The diagnosis is often delayed, and that is why it becomes severe. The Endometriosis Association survey noted a 10-year delay from the symptoms to diagnosis, with 70% reporting symptoms before the age of 20 and nearly 40% before the age of before the age of 15. Next. So pathogenesis, we all know that it is complex, it is multifactorial. You can keep on clicking till the full slide comes. So it is multifactorial. We all know that retrograde menstruation happens. There is coelomic metaplesia. There is metastasis. Stem cells are there in playing the role, and the hormonal manipulations are there. And of late, even the probiotics have come up in a big way in the endometriosis pathogenesis. And role of estrogen is there in the endometriosis. So it is the chronic inflammatory state. Estrogen is the key hormone. There is growth and persistence. Pro-inflammatory effect is there. Vasculogenesis is there. Neurogenesis is there. And estrogen reduction. So maintaining a hypoestrogenism is the logical target for management of endometriosis. Next, please. So their type of lesions, we have already seen that there are different types of lesion. There are superficial lesions. There are typical, the black puckered and the white sclerotic areas are there. Can any one of the, panelists highlight what kind of lesions you have seen in your practice, or can you describe somebody?
Yeah, good evening. Thank you, sir, for making me the part of this panel. So the lesions which I have encountered in the
Unmute your.
I have unmuted. I hope I'm
Yeah,
audible.
you are unmuted. Yeah.
Yeah. So you can find black puckered spots that are very common. Then ovarian endometriomas, chocolate colored cysts are very common. Then on laparoscopy, yellowish streaks and fats and whitish areas, small cystic areas, powder burnt areas, that and extreme fibrosis and adhesions in the stage 3 and stage 4 endometriosis. So we have all encountered both the different grades of endometriosis and the lesions by which we can identify. And sometimes even very small, minute lesions are there, which makes us suspicious that she could be a case of endometriosis.
Yeah. So Dr. Samta has explained very well, and now Dr. Jigyasa will take over the cases further. Next, please. Dr. Jigyasa, over to you.
So let's stick to the clinical points because other details have already been discussed. So let's go ahead with a 16 years old girl, menarche at the age of 10 years, irregular cycles of 22 days, severe dysmenorrhea associated with vomiting and bowel symptoms, and no relief with analgesics. So I'd like my panelists to tell what next. How will you investigate this patient? Would you like to examine her or directly go ahead?
So, hi, I'm Dr. Meeti Bhanot.
So regarding the 16-year-old girl, the first step would be a very, very detailed history, taking into account her, the menstrual history, besides the other medical histories, the symptoms, any psychological aspect to the pain, what is the level of absenteeism from the school. So and any addictions in these 16-year-old, any history of smoking, vaping, all these need to be taken into account. Then the next step is with consent. And if the patient is comfortable, we go in for an examination, which could include a per rectal or per rectal vaginal examination. And then again, even, if the examination findings are positive or negative, we go on to the next level of investigations, which include some basic blood levels and an ultrasound of the whole abdomen. Per se also could offer her a transrectal or a transperineal ultrasound if need be, depending upon the findings.
So what are we expecting on the ultrasound?
On the ultrasound, it could be just no abnormality detected, or we could have some space occupying lesions, or we could also have some symptoms of cysts, or, nothing available.
We have to
Imaging
look
may
into
or may not be positive.
I can add something?
Yeah, please.
Yeah, we can see any obstructive lesion also, like in the genital tract, which can also lead to her pain, like she may be having hematometra or.
But actually, she is actually having her periods, you know.
Yeah, she is
having regular cycles, no?
Yeah, regular cycles.
Having regular cycles, but she's having pain. So we may find some component if there is any partial or. So that can also be there, and the cystic lesions of the ovary.
Okay, so mostly what we see in cases of adolescents, that the adolescents normally have a superficial peritoneal disease, most of the patients. And so the ultrasound finding is normal in this case. So when do you suspect endometriosis in adolescents?
On the basis of clinical history also, we should keep our index of suspicion high. Because of severe dysmenorrhea not responding to NSAIDs, and also especially if associated with bowel and bladder symptoms, vomiting, and causing her to miss her school. So that is significant, and we can keep a clinical diagnosis. And even if a normal ultrasound is there, we should not think that the endometriosis cannot be there, and we should start the treatment considering the diagnosis of endometriosis.
Next slide, please. Okay. Next. So the most important thing is most of them present with atypical symptoms and are treated empirically. Diagnosis is often delayed in adolescents for a period of more than 6 to 8 years until and unless we have a high index of suspicion. Next slide, please. So what are the risk factors of adolescents endometriosis?
So in adolescents, there could be a positive family history. There could be some genital malformations, which would be mostly obstructive. They usually give a history of short menstrual cycles and an early menarche. Now, when a patient right from menarche gives us a history of, dysmenorrhea, not being relieved by NSAIDs, that is a strong, indication of endometriosis, adolescent endometriosis.
So now you have suspected adolescent endometriosis. How do you go ahead and treat her?
Okay, like any adolescent, we first give her some lifestyle advices, including some diet modifications and exercises. Along with that, we first offer her the first line treatment, which is NSAIDs. We first start with the mild NSAIDs, and if no relief, we may offer her, depending upon the weight and a combination of NSAIDs. That is the first line of treatment. If the patient is relieved and the symptom is dysmenorrhea and she is relieved comparatively and well with the just NSAIDs, we continue that for as long as we can. But if there is no relief with NSAIDs, then we offer her the next line of treatment, which goes to the hormonal levels. And most probably the first line of treatment is the oral contraceptive pills. We plan to start it in the lowest possible dose, and we may escalate depending upon the symptoms.
So, oral contraceptive pills, the lowest dose possible, that we talk about the estrogens.
Estrogen, yeah, combination oral contraceptive pills. We start with that first. And we could also give her the progesterone, the progesterone, the Dinogest or the Endoreg. But first line, let's start with oral contraceptive pill in the lowest dose and then go on to the next level. Because once if we start with the Dinogest, then we may not have, if she's not getting any relief and all, we should go in a step manner fashion in order to relieve the symptoms.
Anyone else want to add upon whether the pill should be given on a continuous basis or the cyclical one?
Yeah, the pills should be given on a continuous basis that are more beneficial in comparison to the cyclical ones. So that has been documented. So we can give continuously for 3 months and then we can give a break, or even for a 6 months they can be given. So that is documented. But continuous pills have got a more advantage in comparison to cyclical ones.
So, because the patient is an adolescent, it is always better to go step by step treatment wise. So, if it is my patient, I would first give her a cyclical for 1 or 2 months. If I feel that there is relief, let her continue. If there is no, then we go on to the continuous level. And again, if there is no relief, then we go to the next level of treatment. Because she's a 16-year-old and she has a long journey for endometriosis. So it is best to go in a step ladder fashion.
Any choice of oral contraceptive pill regarding the progesterone?
So, there is Drospiron or Dinogest pills are available, and they are a good first line drug pills for endometriosis.
Anyone else would like to add something? So basically desogestrel and levonorgestrel, these are the two combinations which are mostly preferred. If the patient is having any androgenic problems like acne, hirsutis, then we can go ahead with drospirenone or cyproterone acetate.
One
Next
point I
is-
would like to highlight here is nowadays we have to be clinically keep a very high suspicious about endometriosis in an adolescent, because it is very clear based on the guidelines that it can be diagnosed on clinical basis, and usually in adolescent late diagnosis is one which can lead to further complications. So you have to keep this diagnosis in mind even in adolescent and start treating them accordingly. If they are not responding to the basic treatment and NSAIDs and OC pills, they are not responding, then you should evaluate them further.
Another thing I just wanted to know, aren't you worried about the height of the patient or the early closure of the or of the epiphysis once we are prescribing estrogen containing pills?
So yes, so in adolescent, if she has started, if she has attained menarche, then it is assumed that her epiphyseal closure is there. So of course, OC pills is not the first choice, but you can start it.
Yeah. And another question for the expert, Dr. Sanchita, is if OC pills are not working, now what next?
Of course, what we have discussed, progesterone is another important this thing, and we have very good new drugs available which helps in relieving the pain part in these adolescent girls. And if the girl is sexually active, LNG IUS can also be offered. That is
Should
what
we go ahead with the laparoscopy if a patient is not responding
Yes, of
to
course,
anything?
laparoscopy, again, see, in adolescent or in any lady, a laparoscopy is, of course, is not the very good choice because we have good medical treatments available. One, we need to preserve the ovaries. We need to avoid whatever possible damage which surgery can cause in a young girl. But if the pain is too bad, if nothing is working, then yes, of course, laparoscopy.
And any other panelists would like to highlight upon the laparoscopic findings in adolescent endometriosis because the lesions are not very typical. Yeah. So see, we see very subtle lesions here. and many times these are missed until and unless we know about it. Even clear blebs or red flame lesions. So we don't see the typical lesions like black puckered lesions. Those things are not seen in endometriosis in adolescents because these are early lesions. So we will not see the fibrosis, we will not see the hemosiderin deposition here. So that is very important.
Again, now, Dr. Jigyasa, which I would like to say is the clinical diagnosis is main. Initially, we used to say laparoscopy is there for diagnosis, but for diagnosis, you don't have to go for laparoscopy. In a adolescent girl, for ultrasounds, if you're not able to do a transvaginal ultrasound, you can do a transrectal ultrasound, or you can do a transperineal ultrasound. And MRI is also can be done if required. And laparoscopy, even if you do clinically, if she is symptomatic, you have to put her on medication.
Definitely, laparoscopy is the last resort. But in case we are doing a laparoscopy as a last resort, if the patient is not responding to any of the medical treatments, then it should not be a diagnostic laparoscopy. We should again go ahead and treat the lesions at the same go. I think we proceed with the next case, Dr. Aradhana.
Yeah. Next, please. We can go to the next slide.
Next.
Again, next. We have already discussed all this. Please, next, please. Next case. Next.
Case 2, basically.
Again, case 2.
We should have shared these slides while discussing.
So,
People would have noted it.
so that's fine. You all have already discussed. Now, coming to the case 2, Mrs. SJ, a 28 years old female. She's married for 3 years, IT professional, and chief complaints are dysmenorrhea for 2 years, gradually increasing in intensity. And she is trying to conceive for 2 years. So infertility of 2 years is there. Occasional deep dyspareunia is there. She had menarche at 13 years of age, regular cycles, 5 days bleeding, and increasingly painful periods requiring NSAIDs. Next, please. So in this case, sorry, yeah. So, and she is, of course, the para 0 and past medical, no, nothing significant, no medical or surgical history. Family history, mother had hysterectomy at 42 years for heavy bleeding, cause not clear. She is stable. The BMI is 22 kg per meter square, no palpable mass on abdomen. Pelvic examination, cervix, uterus normal, retroverted, mobile, mild tenderness in posterior fornix, and no adnexal mass. So how to proceed next? How to proceed in this case? Any one of the experts. What investigations will you do?
Ultrasound findings?
Yeah. So
Normal.
ultrasound was normal. No endometrioma, mild tenderness on probe, and the hormone profile was normal. Tube test, HSG were patent, and semen analysis was normal. So what else, or, how will you proceed in this case? She's already, any of the panelists can answer?
Hello, ma'am.
Yeah, hi, Apurva. Yeah.
So, ma'am, here she is a different case than we had the previous case. Here, the concern is not just pain. Here, the concern is fertility as well. So, here we have to talk to the patient and discuss regarding the medical and the surgical management. And here, laparoscopy for such patients would be a good choice in case she's going for a fertility treatment, because whatever hormonal therapy or medical management we give is not going to help in her fertility. It will further suppress her fertility. Already she's 2 years or trying for a conception, and further giving her medical management and delaying her pregnancy journey would not be advisable. So here laparoscopy would be a good choice. Even we do not have.
So sorry to interrupt, but this is a very good point, and point to be noted that by all that, of course, the surgery is the first choice in this patient, and medical management will further, worsen the disease. So if patient is willing for pregnancy, then definitely medical management is not the choice. Yeah, next, continue.
So when we go for a laparoscopy here, already we've done the ultrasound and we have found nothing. So endometriomas are not there. So if we do a laparoscopy, probably it would be
clinically we can say that it would be a milder disease of, but surgical treatment will definitely help because then we can actually stage the disease. Moreover, at times the ultrasound is not going to give the complete information, and on a laparoscopy and actually seeing the abdomen will give us more knowledge. And if there is anything, we can actually see and treat at the same time.
So what will you discuss with your patient before going for laparoscopy? That, what counseling you can think that,
So
before the
we'll,
laparoscopy?
so we'll have to tell the patient that although on the ultrasound we are not finding any such things on the, like endometriomas are not there, but still on doing a laparoscopy, if we do find anything suggestive of endometriosis, we'll be treating the same. Along with the laparoscopy, if in this case HSD has been done, but if it would not have been done, we could have done the chromoperturbation at the same time. We could also see the tubes and
Still we
everything.
can do and see the, how
Yeah.
much spillage and all. So
Yes.
it's the point here is that, of course, we will discuss that we will not only, there's no role of just a diagnostic laparoscopy. We will treat the lesions at the same time, whatever we may get. So that counseling should be done. Next, please. Next. Yeah. So next, keep on pressing it till one slide comes completely. So this is a case of, as we have discussed, the operative, so role of laparoscopy we have seen. It was staging 1, minimal endometriosis was found. No endometrioma was found. No pelvic adhesions, bilateral tubes, normal spillage was seen. Small superficial endometriotic deposits in the posterior cul-de-sac and uterosacral ligaments. Next, please. So operative laparoscopy could be offered as a treatment option for endometriosis associated infertility according to revised ASRM stage 1 and 2 endometriosis, as it improves the rate of ongoing pregnancy. Next, please. And next, so these were the typical laparoscopic findings. We have already discussed the white puckered spots, then the powder burn areas and the peritoneal deposits. So they were treated at the same time. Next. So how to do the staging of endometriosis, if anybody can highlight? Any of the panelists? How many panelists are here? Doctors?
There are many classification system, though exactly I cannot. So there are, that is Enzenian's classification system, then fertility classification system, then what we are looking after, whether it's a superficial or deep peritoneal implants are there, how much enclosure is there, whether ovaries are involved or not, and you give different numbers to that, and then you add the numbers and then you get the score. So that is one of the classification system for endometriosis. Then there are fertility classifications. I exactly cannot quote.
So next slide will highlight that. Next, please. So there's revised AFS and ASRM staging systems of endometriosis based on a point system, as highlighted by Dr. Samta, that takes into account the location, extent, and the depth of the disease in relation to the pelvic structures. So stage 1, there is minimal disease where 1 to 5 points usually comprises of the superficial endometriotic spots or adhesions like found in this case. Stage 2 is mild, 6 to 15 points, can be a few deep peritoneal lesions solely or in combination with the superficial lesions or flimsy adhesions. So this is the stage 1 or 2, minimal or mild disease. Next, please. Next slide. Next slide, please. Excuse me, who is changing the slide, please?
I am changing, madam.
Please change it. Yeah. And this is the stage 3 and 4 disease where moderate 16 to 14 points are given, which includes the endometrioma by itself. So straight away endometrioma gets the 16 to 20 points. And in combination with the superficial or deep endometriosis and dense adhesions, then there comes the stage 4, which is a severe, where more than 40 points are there, where severe adhesions are there. As you can see in the picture, that is involving, the bladder and bowel, and the severe damage to the POD completely obliterated. That becomes the stage 4 disease itself with the more than 40 points. So this way the staging is being done. Next slide. So this treatment of mild endometriosis with infertility, next. We have already discussed. And next, please. And yeah, so according to the current guidelines, the surgery improves the spontaneous pregnancy rates for women with the minimal to mild stage 1 and 2 endometriosis, offers the diagnostic laparoscopy with excision or ablation, or with or without adhesiolysis when infertility is indicated, and do not offer the hormonal suppression as the fertility improving strategy. Whatever hormonal OCP, progesterone, GnRH agonist relieve pain, but they do not improve the spontaneous pregnancy rates, and they should not be used when the patient wants to conceive. So that should be the message. Next, please. And so management plan for this case is can anybody highlight what will be the management plan for this case?
So, ma'am, here the management plan will depend upon not only that she has the ASRM1, the mild endometriosis, but also her age, her reserve semen parameters, and the tubal patency. If she's young, if the reserve is good, if the semen parameters are good, tubes are open, then she can be left for spontaneous conception for around 6 months, and then she can be later on taken off for IUI, and if that doesn't help, she can go for IVF. However, if the reserve is reduced and there are other parameters contributing to infertility, then probably the spontaneous conception time would be reduced and she will be taken up for ART earlier.
Yeah, so very validly, nicely explained that after surgery for the minimal or mild disease, the guidelines recommend that if the condition of the patient AMH and her other parameters permit, then you can allow her to 6 to 12 months for spontaneous conception. And if she's not conceiving, then you can go ahead with the IUI and IVF without wasting time. Next, please. Next. So, Dr. Jigyasa.
Yeah. Coming to the next case, she is a 28 years old college student, unmarried but sexually active, no previous pregnancies. She presents with severe dysmenorrhea for 2 to 3 years, pain worsening over the last 6 to 8 months, vomiting during menses, occasional dyspareunia, no vowel symptoms. Menstrual history, regular periods, menarche at 12 years, past treatment, partial relief with NSAID. She has been taking NSAIDs irregularly. Next, please. Next slide. On examination, abdominal examination, no palpable lump. Pelvic examination, uterus normal size, retroverted, restricted uterine mobility, left ignacial tenderness. And on transvaginal ultrasound, left ovarian cyst 4 centimeter, ground glass appearance, no septations, and no solid components. Next. Next slide, please. So what is the plan? What is the management in this case?
So in this case, we already are assuming that all the medical management has been tried on her and still her symptoms are not being relieved.
It is only the NSAIDs that we have tried. We have only tried the NSAIDs.
Then definitely, if we have only tried off with the NSAIDs, then we'll move to the next line of management, that is oral contraceptive pills, continuous or cyclical, that we have already discussed. And further on, Dynogest and all, we'll first of all go in with the medical management. But if still there is no relief with the medical management, and especially in this case, there are bowel symptoms as well. So I think an endometrioma of 4 centimeters. So I think we can proceed with laparoscopy, and in this excision of the cyst, that is cystectomy, would be an advisable option. So we all know that we should not just basically puncture the endometriotic cyst. That is not a beneficial, because of there is a risk of recurrence within 3 months. So it's always the excision cystectomy is the best treatment. And in this case, since she's a young girl, so we have to be very careful preserving the ovarian function. So as already highlighted by Dr. Pratik, the hilum, there shouldn't be, we shouldn't try to coagulate more and more at this, so as to minimize the risk of ovarian damage and the risk for the follicular damage, and remove as much as possible the endometriosis and the cyst which is possible. And further on, the post-operative hormone therapy for the recurrence would be a good option in this case. Post-operatively, we would like to give a hormonal suppression therapy so that since she is a young girl and if she is not planning any kind of if not planning pregnancy, so post-op hormone therapy for the prevention of recurrence would be advisable in this case. And the other treatments which are being given, though we all are not practicing, that is your Luna and presacral neurectomy. So they have their own disadvantages, like with the presacral neurectomy, you can have intraoperative bleeding. Then further, there are chances of bladder complications. So I would go in with the excision of cystectomy in this case.
Dr. Samta, she is still not married. And we don't know when she'll plan pregnancy.
One point which I would like to highlight here is, Dr. Samta, when we talk about presacral neurectomy and all, I think they are very, very technically, you need to be very, very technically skilled for it. Otherwise, you will be landing up in more complications.
That's what I said, though we all are not doing, but
Luna is now in the guidelines. They say Luna
It
is not to be done.
But you
And
need to
for
be
this patient-
technically expert. That is
Yeah.
what I want to be
And for
want to
this
highlight.
patient, we should definitely try to go for oral contraceptive pills with Dynogest, because oral contraceptives generally don't reduce the size of the lesion. But with Dynogest based oral contraceptive pills, we can look that whether the size is reducing and her pain is reducing, and we should try to postpone the laparoscopy as far as possible. I think I would do that. And she's also sexually active, so we can even offer her a LNG IUS so that her pain gets reduced. So I would prefer not to do a laparoscopy for this patient.
What about giving only Dynogest, not the contraceptive pills?
That's also
So,
okay.
That is also a good idea.
Yeah, so in my opinion, also the only
Dynogest
can
Only
be tried,
Dynogest
and
is
we have
also
seen that endometriotic cysts are disappearing, even the smaller one. So she's having 3-4
And you can
centimeter.
easily continue it for the
6
study
months,
says till 5
yes.
years also.
5
Yeah.
years.
But she's sexually active, so she will need some additional contraception
Contraception.
with that.
Yes.
So either she can go for LNG IUS, so she will not be requiring that. And that will be like one step only, not the daily
Also,
medication.
with such severe pain, adding Leupride with an add back may help.
What about a
We
newer
have just
drug,
taken NSAIDs
GnRH
and we have not
antagonist?
taken anything else. So let us first try this. And Leupride is a
I think
second
nowadays,
level
yes,
of
we get
treatment,
very
not the first
very
level
good
of
results
treatment.
with Dynogest, and also
Dynogest.
usually we don't
Yes.
have to use
Do it,
Leuprolide.
but
I have
just one
hardly
point,
using it.
if she's already 28 and with endometrioma, and if she's having, you know, a lot of pain, a severe pain, which is not getting relieved, then we might do a laparoscopy,
Yes.
complete surgery, and then LNG IUS in follow-up. Because she might blame that you have not done anything for my, the progressive disease.
No,
Just
then
with
we can
medication,
go
if
by
not
step.
relieved with
For
medication.
pain, I think the Dynogest should be the first because that offers, that is
See,
And
where
if
it
the pain
acts.
is not relieved by
But if
Dynogest, we have
even
other things also.
Then we have antagonists also, and we should try to
exactly. I
use
mean,
the
We have
laparoscopy
antagonists
as
also in our basket.
laparoscopy should be taken as a last resort because
Yeah, that's what I'm saying. That's what
there
I'm
is
saying.
a
If the pain
very
is not
high,
relieved,
so there is a very high
last
possibility
resort, not the
of
first.
recurrence
Yes, of course.
also. So
course.
Recurrent surgery.
laparoscopy is
And
not the
also,
solution. She will have to be on medical treatment post that, and she need to understand her condition. So with endometriosis, you have to be very clear that, see, this is the treatment which we will be offering you, but this is not going to go away. You have to be on
But
constant follow-ups for
we
this.
have to understand that she's already stage 4 with endometrioma. And if it is not relieving, that we have to keep an eye on that endometrioma and her stage of the disease. For,
Usually
We have
with
disease,
Dynogest
then
pain
we can
relief,
go ahead with Dynogest.
the
And if the pain is not
size,
relieved by Dynogest, then we can go ahead with a GnRH antagonist.
for the antagonists, antagonist we can
even
go
if
for. And
Change the slides, please.
even if the size of the endometrioma doesn't regress with medical therapy, at least her pain part would be
pain
better.
goes away.
So
So
then also
endometrioma
it is
can be
worth
there.
giving a medical treatment. If her
Next.
pain is relieved, if the size is not increasing, though it is not regressing also, it is fine to be there.
It's fine.
We can go ahead with a long-term therapy, medical suppressive therapy, and offer a surgery only once she gets married near the
Planning for
time once she
pregnancy.
wants to plan for the pregnancy.
And
So
she's
now
having difficulty conceiving.
Yeah. Yes. Next. So in case we take her up for surgery, once she wants to plan and not able to conceive, she is a case of fertility. So will you plan to do a AMH for her or not?
Yes.
Yes.
Yeah.
Yes.
Yes.
So
Operative, yes.
Yes.
Yeah. So
even
that
if
is very
you are
important
doing it
that
in
we
any
have to
young
do
girl
a
also,
AMH
then also.
pre-operatively and counsel the patient about the chances of decrease of the AMH. Next, please. So we have already discussed all these medical options. I think we go ahead and discuss the fourth case. You can go to fourth case now. Yeah, this is an important slide. See, we have to understand there is a therapeutic window and once we are doing the medical management, and that therapeutic window is in the range of 30 to 50. If medical management, once we are doing it, if the estrogen level is between 30 to 50, it helps in regression of the disease and does not cause the hypoestrogenic side effects. That is very important to understand. Dr. Radha, we can proceed with the fourth case.
So this is the fourth case, and so Mrs. VP, 35 years, female, complain of trying to conceive for 5 years. Menstrual history, she has regular cycles, 4-5 days by every 26 days. Dysmenorrhea is moderate to severe, heavy flow. On ultrasound, there are endometriotic cysts 3 to 4 centimeter in the right ovary. Her AFC count is 4, left ovary, no cyst, AFC is 5. Bilateral spill plus on HSG, semen analysis normal, AMH is 1.2 nanogram per ml. Treatment history, medical management, 6-month Dynages with Lupride depot, 2 times was given. Underwent 3 cycles of ovulation induction with Letroz, 5 milligram with follicular monitoring and timed intercourse, but treatment failure was there. 2 cycles of IUI with Letroz, again treatment failure. Next, please. Next. So what next? What will you do in this such patient? She's already trying to conceive for 5 years. Previous slide, please. Any of the
She should be offered IVF because her age, already IUN treatment done. We can check her AMH, whatever the values are at 35 must have
AMH is
been
1.2.
1.2.
And there is endometrioma.
So laparoscopy would be preferred only if there is technical difficulty in performing an IVF, over retrieval and all. Otherwise, since IUI and everything is failed, she should be offered IVF only.
Any other panelist?
Yeah. Yeah, I also feel that IVF is a better option for her, and even her antral follicle count is also just on the margin regarding her age. So it is just 10. 4 and 5, that's 9. In fact, her antral follicle count is also low. A better option would be IVF, and as Dr. Sanchita has highlighted, only laparoscopy would be beneficial before ART if there are big cysts, and we know that while retrieving the ova, you can rupture the endometriotic cyst. So in those cases, yeah, definitely a lap earlier would be beneficial. Otherwise, she is.
So will you do any pre-IVF hormonal suppression in this patient?
No, not needed.
Yeah, so that we have discussed that hormonal suppression would worsen. So next slide, please. Next. Next slide, please. So current guidelines of ASHRAE and NICE SRM, they review and about the endometriosis and infertility, that if surgery fails and endometriosis infertility factor exists, proceed to ART. For moderate to severe disease, which is a stage 3 to 4, the benefit of extensive excisional surgery on fertility is less clear. Individualized discussion with the early involvement of fertility services is advised. If IVF is recommended path, and the IVF is the recommended path when pregnancy does not occur after appropriate surgery. or when other infertility factors are present. So map the disease pre-op well, refer to the deep multi-organ disease to the specialist center, do a surgery. If at all you're deciding to do a surgery, go for with a complete surgery, at one go. And of course, discuss the oocyte cryopreservation when significant ovarian surgery is planned and when future ovarian function is at risk. So very well explained by all of you. Next, please. So IVF is the choice when the stage, the stage of the disease is higher. That is the purpose. So practical clinical algorithm is there. Infertility with endometriosis, evaluate her age, AMH, semen and tubes. Stage 1 and 2, laparoscopic excision works better. And natural conception can be tried, otherwise IUI or IVF. For stage 3 and 4, consider surgery if anatomy is distorted or if the severe pain is there, and IVF is preferred. In these cases, as Dr. Samta has already explained, that if very big endometrioma and you might, fear to rupture those endometriomas, then only the surgeries, otherwise IVF is preferred. Next, please. So endometrioma less than 4 centimeter, proceed with IVF. More than 4 centimeter, consider cystectomy. And failed treatment, do IVF and ICSI. Next. So key guideline messages are there of this panel, that hormone therapy is the first line treatment when patient is not planning pregnancy. Surgery improves fertility mainly in minimal to mild disease. IVF is most effective treatment for moderate to severe cases. Avoid repeated ovarian surgeries. So go with the proper plan when you're going for surgery. Hormone therapy does not treat infertility. So if a patient is infertile, don't waste your time in the hormone therapy or hormonal suppression. Next. I think it was a wonderful discussion. Thank you, everyone. Dr. Jigyasa, you would like to say something? Or Dr. Sanchita?
Wanted to again suspect endometriosis, suppress the disease, do surgery only once the patient is planning, and individualize the case. And fertility preservation is very important. And we have to counsel the patient about the long-term treatment and the chances of recurrence also, which is very important.
So any one-liner messages from all the panelists?
Yeah, one important point which I would like to highlight is laparoscopy for the diagnosis should not be done ever. For endometriosis, we have very good ultrasound findings. We have other modalities, 3D ultrasounds, transperineal in a young girl. You should always use those modalities for diagnosis. Another is CA-125 also is not recommended for diagnosis of endometriosis. So every patient who comes with ovarian cyst, they always come with CA-125. So that is not a part of diagnosis for endometriosis that we should now incorporate in our clinical.
Dr. Astha, any expert comment?
Ma'am, the treatment of the patient should depend upon her symptoms, whether it is the pain or the fertility, and that should decide medical or the surgical management.
Yeah, in the medical management, combined oral contraceptives are the first choice, and they should be tried first.
I think continuous should be preferred.
Yeah.
Continuous should be preferred.
At least for 3 to 4 months. At least for 3-4 months.
Dr. Mithi, is she here?
Yeah, I think you'll have to counsel the patient that you will live with the disease till the time you attain menopause and sometimes even later. And you will have to keep coming back to us with different symptoms at different ages, and just prepare her for that, counsel her.
Yeah, I would like to add one more point, though we haven't discussed regarding when if she has completed her family. So earlier it was we used to have this notion that it is hysterectomy along with bilateral salpingo-oophorectomy. So that I want to highlight that it is not that in each and every case you have to do a bilateral oophorectomy. So even removal of ovaries is not mandatory to treat the endometriosis.
That's a very valid point. Do not remove everything. Ovaries can be conserved after proper discussion, and of course disease progression and everything after seeing the disease stage. And next, I think Dr. Shweta is there left for the expert comment. Dr. Shweta?
I think most of it is covered only. And I think we need not just confirm the diagnosis only. If the patient is having pain and she's relieved with combined oral contraceptives in a younger age group, we should tell them to continue it and not stop it even if the cyst has regressed after some time. So until unless she's planning pregnancy, she should continue some form of treatment so that it doesn't increase.
Okay.
So whenever you are continuing the contraceptive pills, you have to keep her on a regular follow-up for
definitely
evaluating the other blood parameters also.
Yes.
We cannot just keep taking it without
And
monitoring.
as very well explained by Dr. MC Patel, sir, that document your counseling points to her because it's a long-standing and bad disease. So your document should be proper about the counseling and the follow-up with this patient. So with this, I would like to end, and I would like to thank Dr. Patel, sir, for giving us this opportunity, and to all the panelists, experts, Dr. Sanchita, and all our learned panelists, Dr. Jigyasa.
Thank you, sir. Sir,
Thank you.
MC Patel, sir. I think
We
for this
wish you
opportunity.
our best wishes are with you, Dr. MC Patel, sir. Where are you? Sir?
yes, sir is
I am
there.
here only.
Sir is here.
Sir, it was wonderful that you helped us, all of us on this
Yes.
platform, and we enjoyed doing it.
Yes.
So Greater Noida and Noida are with you. So
Noida and
your
Greater
panelists
Noida.
are from Greater Noida and Noida is there completely.
Yes, yes.
Connected all the sisters, sir.
Yes, my pleasure, my pleasure. But big round of applause for both the learned moderator for moderating this panel and all the panelists, and with expert Sanchita, of course, putting their inputs, making this panel very interesting and fruitful. So thank you very much.
Sir.
Thank you.
Sir.
Thank you,
Shweta,
sir.
be there?
The best of luck for your upcoming
Thank you.
elections. Our support is there. Thank you.
100% support, sir.
In month of April last week or first week of May, there will be communication from Foxy for nomination.
Yes,
So
sir.
first you have to nominate my candidature, and in month of August 1 to 10 there will be election, and see that all the members vote, because many a time what happens, people do not vote because 50% voting is even less than 50%. Total member of Foxy is more than 38,000 voting.
38,000.
Total member is somewhere 50,000, but voting rights 38 something, and voting is just 12,000, 13,000.
Not
So
even
less
50%.
than 50%.
Yes. We'll
But
make
anyway,
sure, sir.
yes. Satabdi, you can
Yes,
proceed.
sir. Thank you, sir. Thank you, sir. First of all, my heartfelt thanks to our program director, our very own Dr. MC Patel, sir. Thank you to Dr. Monica, the convener. Special thanks to Kiran Pandey, ma'am, for coordinating the entire program with the Ghaziabad, Greater Noida, Khora, Makanpur, Kanpur, and Noida societies. Thanks to my co-coordinators, Dr. Monica, ma'am, Dr. Deepika, ma'am, Dr. Nivedita, ma'am, and Dr. Megha, ma'am. Heartiest thanks to our chief guest, Dr. Meera, ma'am, our guest of honors, Dr. S.S. Gulati, sir, and Dr. Archana Verma, ma'am. We had 3 wonderful talks. So thank you to Dr. Kanchan, ma'am, Dr. Prateek, sir, and Dr. MC Patel, sir, of course. Thank you to all the chairpersons, Dr. Kiran, ma'am, Dr. Kalpana, ma'am, Dr. Chaya, ma'am, Dr. Manisha, ma'am, Dr. Archana, ma'am, Dr. Neelam, ma'am, Dr. Alpana, ma'am, Dr. Kanchanmala, ma'am, and Dr. Archana Mehta, ma'am. We had a very, very interesting panel discussion. So once again, thanks to Aradhana ma'am and Jigyasa ma'am and to Sanchita ma'am. Thanks to all our panelists, Dr. Mithi ma'am, Dr. Shweta, Dr. Manisha, Dr. Reshma, Dr. Ritu, Dr. Samta, Dr. Gunjan, Dr. Apurva, and Dr. Vani. So lastly, thanks to Corona Remedies for coordinating the program. Would request all of you to kindly vote and support Dr. MC Patel, sir. Let us ensure that he wins this time. Thank you to all of you. Good night.
Thank you. Thank you. Thank you.
Good night, sir.
Thank you, sir.
Good night, everyone.
Good night, everyone.